So thank you so much for this invitation to bring greetings from the Dean's Office, Faculty of Medical Sciences, and specifically from the Deputy Dean Graduate Studies Office. So Dr. Prof. Trotman has said the successful completion of this clinical research project, which you know is part fulfillment of your degree, is tedious. We know that. But I think we can all agree that valuable skills are and were learned that will not only advance your career, but assist in what we must do daily to offer best patient care, that is, apprise the medical literature. This conference provides a forum to share your important findings, the new knowledge, and also develop that important skill of presenting your work in a very supportive, professional, and collegiate setting. Past presenters have gone on to present their work at local, regional, and international conferences, and some have been awarded conference prizes. Right, Dr. Carvalho? So we ultimately look forward to the publications that will emanate from this work that will not only enhance your CVs, but advance the research output of the Academy. The Department of Child and Adolescent Health, their heads of department, we want to thank Professor Russell Pierre and now Dr. Abigail Harrison, and all the academic and research supervisors, and most importantly, the students, for the work which we'll hear of today, but the department specifically for leading the way. And as Prof. Minerva would say, and a child shall lead them, by inaugurating a resident research forum in this faculty. Best wishes for a successful and enjoyable evening. I'm looking forward to all the many papers. Thank you.
And now I would like to invite our current head, Dr. Abigail Harrison, to bring greetings. Thank you.
Thank you, Chair. Dr. Melbourne Chambers, Deputy Dean, Graduate Studies, and representing our own Dean, Prof. Minerva Thame, our judging panel, Professors Russell Pear, John Lindo, and Maxine Gossel-Williams, our pediatric residents who will be presenting, our wider pediatric family, our friends, well-wishers, good afternoon to you all. It is my absolute pleasure to welcome you all this afternoon to the 3rd Annual Pediatric Residents Research Forum on behalf of the Department of Child and Adolescent Health. And Prof. Trotman already said it's the brainchild, the baby of Prof. Pear, and it has indeed been an excellent addition to our academic calendar. Thank you, Prof. Even in spite of the anxiety that it causes our presenters each year, but they mature, they grow up, and now look at Carvalho in the back, no anxiety, chilling, and just looking fabulous. It is an afternoon that not only will we celebrate research, but we'll celebrate the curiosity, the dedication, and indeed the tenacity that it takes to complete the process. In fact, it was 24 years ago in my graduating year that the department became one of the first, if not the first department, to insist that all DM graduates would complete a clinical research project in partial fulfillment of the requirements for the DM program. This was an excellent decision indeed. To all residents, today we're actually just going to celebrate you. So it feels like stress to you, but for us, it's just a moment of pride and celebration. So thank you for joining us. We hope, as Prof. Trotman has said, that you have learned research is not just about collecting the data or finishing the write-up, but about asking the right questions. Right, Prof. Knight-Madden? It's the research question, challenging assumptions, and ultimately contributing to the improvement of the lives of our children and their families. I extend my sincere gratitude, trust me, to the academic supervisors and the research supervisors that prod you along, and all those, especially your families, that have supported the completion of your projects. So as we engage in today's presentations, let's celebrate the achievements, but also embrace the actual discussions, which will be constructive discussions. Research really thrives on collaboration, and today is an opportunity for us to learn from one another, to refine ideas, and to come up with new ideas that need to be discovered. We look forward to all 13 of the projects. Last year we only had 8, I think, or 9, and this year it's 13. And we look forward to the conversion of these projects to manuscripts in the next 2 years, max. Not 3, not 4, not 5, 2 years. In peer-reviewed international journals. In the meantime, you can go to some international conferences and present as well. So to all of you this evening, I thank you for being here in spite of the warmth. We apologize for the lack of air conditioning. And all I have left to say is let the fun begin.
So one quick thing before we get into the meat of the matter, some housekeeping. Remember to scan the QR code for registration for your CMEs. The judges at the end, you all will deliberate in the Peter Fletcher Lecture Theatre. And just to start off, I would like to thank our sponsors, because without them, it would make that more difficult. So our sponsors today are Abbott and CariMed. So, and just to give the residents just a little boost, to let them know that last year's winner, I'm so proud, Dr. Cavallo, because I saw him shepherding his flock. I saw him shepherding y'all. I've seen him now with the junior residents when they have their proposals to prepare. He's helping. So we are seeing fruit from this conference. So to start us off today, we have Dr. Anita Beckford, who will be presenting on the outcome of very low birth weight infants at the Spanish Town Hospital. Please help me to welcome.
Good evening, everyone, and welcome. The topic of my research project was outcome of very low birth weight infants at the Spanish Town Hospital, 2021 to 2023. The principal investigator was Dr. Bovette Butler. Co-investigators were myself, Dr. Anita Beckford, and Professor Helen Trotman-Edwards and Dr. Aluk Bui. Very low birth weight infants are at a higher risk of mortality during the first 28 days of life due to their fragile health status and increased susceptibility to complications. However, over the past 5 decades, due to advancements in perinatal care, there has been improved survival of these premature very low birth weight infants. The disparity in neonatal mortality rates among very low birth weight infants is widely acknowledged, with significant differences observed between high-income and low and middle-income countries. For high-income countries, the rate ranges between 5.9% to 17.2%, and the rate often exceeds 25% in low and middle-income countries. Data on very low birth weight outcomes in low and middle-income countries like Jamaica remains scarce. The limited available evidence comes from mortality rates reported in 2 studies conducted at the University Hospital of the West Indies. In 2010, a study done by Professor Helen Trotman et al. Reported a rate of 38.1%, and in an unpublished study done by Patterson et al. Between the years of 2012 and 2014, the rate was 41%. There was also a study, an unpublished study done at the Victoria Jubilee Hospital by Banton et al. In 2016 with a rate of 58.4%. Gestational age and birth weight are key predictors of mortality in preterm very low birth weight infants. Mortality rates are inversely proportional to both factors, with the highest rates observed, for example, in infants less than 28 weeks gestational age compared to infants beyond 34 weeks. Now, the rationale for doing this study was that there was no published data on mortality of very low birth weight infants at the Spanish Town Hospital. This study will provide data to inform evidence-based interventions to decrease mortality of very low birth weight infants and overall neonatal mortality. It will also provide data to compare mortality rates over time. Our aim was to determine mortality and factors associated with mortality of very low birth weight infants at the Spanish Town Hospital between January 1, 2021 and December 31, 2023. Our objectives were to determine the proportion of neonates born that are very low birth weight at the Spanish Town Hospital between January 1, 2021 and December 31st, 2023, to determine the very low birth weight in-hospital mortality rate, and to determine the factors associated with in-hospital mortality rate. For our methodology, our study design was a retrospective docket review. The study setting was Spanish Town Hospital, which is the largest type B hospital in Jamaica with a level 2 neonatal unit, which consists of a special care nursery and a neonatal high dependency unit with a 52-bed capacity. We have access to surfactant, portable X-ray, cranial ultrasound, and in terms of respiratory support, we have access to bubble CPAP and 3 mechanical ventilators. Our study participants were all very low birth weight infants weighing greater than 500 grams but less than 1,500 grams who were born alive at the Spanish Town Hospital between January 1, 2021 and December 31st, 2023 without any lethal chromosomal abnormalities or congenital anomalies. Our definitions: mortality was defined as the death of a live-born infant, either in the delivery room or prior to hospital discharge. Outcome was assessed based on the infant's status at the time of discharge from the hospital. Very low birth weight infants were infants with birth weight greater than 500 grams, but less than 1,500 grams, and extremely low birth weight infants had birth weight greater than 500 grams, but less than 1,000 grams. For our statistical analysis, descriptive analyses were performed. Differences between survivors and non-survivors were determined using the chi-square test for categorical variables and student t-test for continuous variables. The predictors of mortality were determined using multiple logistic regression models. Statistical significance was taken at the level of p less than 0.05. Ethical approval for the conduct of this study was granted by both the Mona Campus Research Ethics Committee and the Ethics Committee of the Southeast Regional Health Authority. Study participants were chosen primarily because of study conditions and not because of easy availability or any other bias. Now on to our results. A total of 214 patients met the criteria and were enrolled in this study. 97 participants were male and 117 were female. However, only 183 dockets were retrieved. For the remaining 31 participants, data was supplemented from the neonatal unit admission book, the delivery room logbook, and maternal records when available. The birth prevalence from our study was 1.8% for very low birth weight infants, and the mortality rate was 37.6%. When we looked at the demographics of survivors versus non-survivors of very low birth weight infants, non-survivors were significantly smaller, less mature, and had a lower mean 5-minute APGAR score than survivors. When we looked at outcome by gender, males were more likely to not survive to discharge compared to females. When we looked at outcome by birth weight, mortality decreased with increase in birth weight. As you can see, 97% of infants less than 750 grams died during the study period, compared with only 17% of infants weighing between 1250 and 499 grams. When we looked at outcome by gestational age, mortality decreased with increased gestational age. So we can see that 74% of infants less than 28 weeks died, compared with only 7% of infants with gestational age between 33 to 36 weeks gestation. When we looked at significant factors associated with mortality, very low birth weight infants whose mothers did not have any hypertensive disorders of pregnancy, who did not receive antenatal steroids, who were delivered vaginally, and were males were more likely to die. For very low birth weight infants who were less than 28 weeks gestation, less than 1,000 grams in birth weight, who had a 5-minute Apgar score less than 7, and who had pulmonary hemorrhage were also more likely to die. When significant factors associated with outcome was offered into a multiple logistic regression model, male gender, birth weight less than 1,000 grams, and pulmonary hemorrhage remained independent predictors of mortality. So in conclusion, the very low birth weight mortality rate remains high compared to other upper middle income countries. The independent factors of mortality from this study were male gender, birth weight less than 1,000 grams, and pulmonary hemorrhage. For our limitations, by virtue of this study being retrospective, data collection was limited by what was recorded. So in some cases, required data was missing from patients' medical records. There was also inadequate documentation, for example, with resuscitation, the admission course, and patient outcomes in the nursery records. There was also a missing portion of a delivery room book, along with difficulty in locating complete patient records in the neonatal unit, as well as in the medical records department. And the fact that this was a single site study, the results may not be generalizable to all hospitals in Jamaica and regionally. Our recommendations from this study is for the institution to institute timely administration of antenatal steroids, create institutional guidelines and protocols for managing very low birth weight infants, to establish protocols for the management of pulmonary hemorrhage, and to have ongoing research to track the outcome of very low birth weight infants at the Spanish Town Hospital. These are my references. Thank you.
Thank you, Dr. Beckford. And now we will welcome Dr. Raquel Dawkins to present on the incidence, risk factors, and severity of ROP.
Okay. All right. Good afternoon, everyone. My name is Dr. Raquel Dawkins Tracy, and I'm excited to present my research, the incidence, risk factors, and severity of retinopathy of prematurity at the Spanish Town Hospital, 2021 to 2022. The principal investigator was Dr. Tracy James Powell, and the co-investigators, Professor Helen Trotman Edwards and myself, Dr. Raquel Dawkins Tracy. Retinopathy of prematurity is a serious eye condition that can be seen in premature infants. It is characterized as a developmental proliferative disorder of the retina that occurs in preterm infants due to incomplete retinal vascularization. It is one of the leading causes of childhood blindness. Incidence rates generally have been found from studies to be higher in your developing countries, which Jamaica is one of, compared to your developed countries. As you can see from this table, we're seeing incidence rates of over 30% in our developed countries as compared to the teens in the developed countries. In terms of severity, high-income countries show that severe ROP mainly affects the smaller babies. So the extremely birth weight babies less than 1 kilogram or less than 30 weeks show higher incidence and severity of ROP. This is in contrast to those babies in the low to middle income countries where severe ROP rates are very high, and they tend to impact the more mature babies that are greater than 32 weeks or over 1,500 grams. More than 50 risk factors have been identified from the literature, and gestational age and birth weight are the most identified risk factors. Medical therapies such as oxygen and red blood cell transfusion have also been shown to increase the risk of ROP. When evaluating the ROP screening program globally, it shows that in high-income countries, ROP screening and follow-up are well integrated into their neonatal care practices. However, the low to middle income countries, they still struggle because of the lack of ophthalmologists, and they have inadequate infrastructure that has led to inconsistent screening efforts. As you can see from this study in Nigeria in 2020, they commented that they had a 26% rate of late referrals for these patients and a 26% rate of loss of follow-up in their study. For my rationale, as the number of surviving premature infants increases, so does the incidence of ROP. Unfortunately, really, there has been no studies from the Jamaican perspective, and this study seeks to address that gap by providing information for evidence-based interventions in our setting. Our study aimed to determine the incidence, severity, and risk factors and completeness of screening for ROP at the neonatal unit at the Spanish Town Hospital, Jamaica, during the period January 1, 2021 to December 31st, 2022. The main objectives were to address or assess the incidence of ROP in preterm infants born at Spanish Town Hospital, identify the risk factors that contribute to the development of ROP, to evaluate the severity of ROP cases diagnosed in the study period, and lastly, to evaluate and identify any gaps in the ROP screening process for preterm infants at the Spanish Town Hospital. Our study design was a retrospective descriptive medical record review at the Spanish Town Hospital, which is a type B facility. At this time, it was a 40-bed unit, and we admit up to 340 premature infants annually. We have no in-house ophthalmologists, so all at-risk infants have to be referred to the tertiary hospital, Bustamante Hospital, for screening. Our study population included all babies who met the screening criteria that survived to 6 weeks. So any baby that was less than 32 weeks, if they were less than 1,500 grams, and if they were between 32 to 36 weeks gestational age but had a stormy course or prolonged oxygen therapy. For statistical analysis, data was analyzed using the SPSS software, and statistical significance was taken at the p-value of less than 0.05. Descriptive analysis were done, and differences between neonates who developed ROP and those who did not were determined using the student t-test for continuous variables and the chi-square test for categorical variables. Risk factors were determined using logistic regression models. Some important definitions to understand the results. So very preterm, any baby born below 32 weeks. Very low birth weight, any baby born less than 1,500 grams at birth. And to calculate our incidence rate, we use the number of cases of ROP over the total number of preterm infants at risk that survived to at least 6 weeks post-menstrual age. Ethical approval was granted by the Mona Campus Research Ethics Committee and the Ethics Committee of the Ministry of Health and Wellness. Now, let me share our key results. So during the study period, 155 patients met the inclusion criteria. A total of 66 babies were found to have ROP, with 54 of them being very low birth weight. From this, we were able to calculate an incidence rate of 45.7% among our very low birth weight infants who survived to at least 6 weeks. 72.8% of patients with ROP had mild disease, and that would be classified as stages 1 to 2, while 27.2% had severe ROP, classified as stages 3 to 5. And just to highlight stage 5 ROP, we had 5 cases over the 2-year period, which is significant because stage 5 disease really implies complete retinal detachment and therefore is a proxy for childhood blindness. This pie chart demonstrates that the majority of infants, as you can see here, 82% were very low birth weight, less than 1.5 kilograms. But interestingly, we found 12 babies, that's 18% of our patients, were greater than or equal to 1.5 kilograms. And this is important because when we look at our screening criteria, we're looking at babies who are less than 1,500 grams. But in comparison with other studies from the lower to middle income countries, we know that we see ROP in more mature babies. So of the babies who were greater than 1.5 kilograms in the study, 9 had mild ROP, 3 had severe ROP, none with stage 5, and the mean weight for these patients was 1.69 plus or minus a standard deviation of 0.13 kilogram. For more analysis, risk factors for developing ROP in this study included lower gestational age and birth weight, total days on oxygen, number of blood transfusions, and chronic lung disease. When we placed all of these risk factors into logistic regression models, we noted that total days on oxygen was the only independent risk factor for developing ROP. Infants who had ROP had a significantly longer duration on oxygen than those without. So we actually saw like ROP patients had 36 days on oxygen compared to 14.9 in those without ROP. In evaluating the completeness of screening, only 87.3% of at-risk infants underwent screening for ROP. And while this percentage may appear to be high, even one missed case in this vulnerable population represents a significant opportunity where blindness could have been prevented. Similarly, 68.4% of patients returned to Spanish Stone Hospital for follow-up. 45.8% of infants were screened after 6 weeks, but there was no difference in the occurrence of ROP in the infants screened at 6 weeks versus those screened after 6 weeks. So in conclusion, this study found a significant incidence rate of ROP among our very low birth weight infants, which was in keeping with other low to middle income countries. Risk factors identified included lower gestational age, birth weight, number of blood transfusions, chronic lung disease, and the duration of oxygen therapy, which proved to be the only independent risk factor for ROP. We had significant loss to follow-up of patients during the study period, and screening criteria from Spanish Stone Hospital seems to be robust because it captured majority of the patients with ROP. Although the study provided valuable insights about the study condition, the limitations that need to be acknowledged was that we had a relatively small sample size. So doing comparisons in terms of patients with ROP and those without may have proved problematic. It was a single center study, and thus you cannot generalize this study to other centers in Jamaica. Missing records definitely affected the completeness of study, and as a retrospective study, we can only use the data that is recorded. From our study, we recommended to have written protocols and guidelines on oxygen therapy and monitoring in the form of posters, to review the screening criteria at Spanish Stone Hospital to include all babies less than or equal to 1.7 kilograms based on what we found, to use visiting ophthalmologists and our telemedicine systems to decrease the rate of loss of follow-up and lack of screening, to implement a tracking system to ensure babies present for screening and return to follow-up clinic, parental education being very important, informing them that, the importance of it. So future studies, after we have addressed the gaps in screening, to track the incidence and outcomes of ROP at Spanish Stone Hospital. I thank you. These are my references.
Thank you, Dr. Dawkins. And now we welcome Dr. Alan Breyer to tell us about surfactant replacement therapy at the University Hospital of the West.
Good evening, all. This evening, I have the pleasure to present the research topic, the outcome of preterm neonates treated with surfactant replacement therapy at the University Hospital of the West Indies, 2017 to 2021. My research supervisors were Professor Minerva Thame and Professor Helen Troutman-Edwards. I have no disclosures. So before we get to the meat of the matter, let us lay a quick foundation. Why are we giving surfactant to preterm neonates? RDS. Respiratory distress syndrome of the newborn is an acute lung disease resulting from surfactant deficiency, which leads to alveolar collapse and non-compliant lungs. And this is a significant cause of morbidity and mortality among preterm neonates. Exogenous surfactant therapy efficaciously improves lung function, specifically lung compliance and oxygenation, and shortens the clinical course of RDS. Now, according to the European Consensus Guidelines on the Management of RDS 2022 update, patients who should receive SRT include neonates under 30 weeks who required intubation for stabilization, and premature neonates with a fraction of inspired oxygen of greater than 0.3 on continuous positive airway pressure support of greater than or equal to 6 centimeters of water, or if lung ultrasound suggests a need for surfactant. Surfactant may be given prophylactically to at-risk preterm neonates in the delivery room or as rescue therapy to babies with an established diagnosis of RDS. Surfactant administered within 2 hours of life, termed early rescue therapy, is associated with better outcomes, a lower risk of bronchopulmonary dysplasia, pulmonary air leaks, and mortality. SRT may be given as an initial dose with subsequent repeat dosing should oxygen and ventilation requirements indicate that need. Complications of SRT include transient bradycardia, oxygen desaturation, and endotracheal tube blockage. The rapid improvement in lung compliance seen with SRT necessitates close monitoring of ventilatory support in order to avoid or prevent the occurrence of lung injury and result on pulmonary hemorrhage and pneumothorax. Apologies. So though SRT has been established internationally by numerous clinical trials and meta-analyses to improve neonatal morbidity and mortality, there have been limited SRT outcome studies in Jamaica and the Caribbean. A previous study done at the University Hospital of the West Indies indicated that there was no difference in outcome between infants treated with surfactant and those who were not. With the increased availability and accessibility of surfactant at the UHWI over the past 10 years since the last study, we thought it would be instructive to review the outcome of infants treated with SRT. So our aim was to compare the outcome of preterm neonates at the UHWI who received SRT, surfactant replacement therapy, with that of those who did not receive SRT during the period 2017 to 2021. Our objectives for this study were to document the characteristics of neonates who received SRT compared with those who did not, to identify the complications associated with SRT administration, and to compare the comorbidities of neonates diagnosed with RDS who received SRT and those who did not receive SRT. This was a retrospective descriptive docket review from January 1, 2017 to December 31, 2021 at the Newborn Special Care Unit at the UHWI, which has 24 Level 2 Special Care Unit beds and 6 Level 3 Neonatal Intensive Care Unit beds. Blood gases, baseline laboratory investigations, and portable radiographs are available. And of note, SRT at the UHWI is exclusively given as rescue therapy. So let's review the specific criteria that determined our study sample. We included all inborn neonates greater than or equal to 24 weeks and less than 37 completed weeks gestation with a birth weight of greater than or equal to 500 grams and a diagnosis of RDS who received SRT, as well as neonates with the same gestational age and birth weight criteria who did not receive SRT. Our exclusion criteria were as follows: neonates with major congenital abnormalities, cyanotic congenital heart disease, pneumothoraces prior to SRT, and a history of intrauterine growth restriction. This flowchart portrays the process by which infants were identified and included in the study. 338 preterm neonates were identified from the special care nursery admission book with a diagnosis of respiratory distress or respiratory distress syndrome. Unfortunately, due to missing data, 98 were excluded. A further 98 neonates were excluded due to dockets confirming diagnoses other than RDS, and based on our exclusion criteria, resulting in the final number of study participants of 148, 81 who received SRT and 67 who did not. The CRIB2 score was calculated for all our study participants and was used to assess mortality risk. CRIB refers to the Clinical Risk Index for babies, and this is a clinical tool used to assess the initial mortality risk of a preterm infant by taking into account a number of factors at the time of admission to the NICU. Importantly, a higher score indicates a greater risk of mortality. Regarding statistical analysis, descriptive analyses were performed using the Statistical Package for Social Sciences version 29, and differences between the two groups were analyzed using the chi-square test and/or Fisher's exact test for categorical variables, student t-test for continuous variables, Wilcoxon rank sum test to compare medians, and statistical significance was taken at the level p less than 0.05. Ethical approval for the conduct of this study was granted by the Mona Campus Research Ethics Committee. So what did we find? As shown in Table 1, infants who received surfactant were significantly lower mean gestational age and birth weight. The head circumference, birth length, and 5-minute APGAR score were lower in the surfactant group compared with the non-surfactant group, and there was no significant difference in the sex distribution between the two groups. This table shows that infants who received surfactant had significantly higher median CRIB2 scores, and remember we mentioned that a higher score indicates a greater risk of mortality than those who did not receive SRT. In the SRT group, 39% of neonates died compared to 3% who did not receive SRT. When we reviewed the survivors in the study, we noted that those who received SRT were less mature and more clinically unstable at birth than survivors who did not receive SRT. And neonates in our study with a birth weight greater than 1,500 grams had excellent survival rates, though, with 95% of those who received SRT surviving to discharge, and 100% of those who did not receive SRT also surviving. In this figure, we see that pulmonary hemorrhage and pneumothorax were the two most common complications associated with SRT. And with respect to comorbidities, infection was the most common comorbidity, with 62% of neonates overall having presumed or documented infections. A significantly higher number of patients in the non-SRT group were noted to have septic ileus. Nevertheless, there was no significant difference in other infections. Of note, there was a significantly higher occurrence of bronchopulmonary dysplasia and retinopathy of prematurity in infants who received SRT. We faced limitations mainly related to missing data. These factors must be considered when interpreting our findings. So due to missing data, we were unable to confirm the diagnosis of RDS for a number of patients. CRIB2 scores also may have underestimated the clinical severity of some of our infants because normal values for temperature and base excess were used to calculate the score when these values were missing. The timing and number of doses of SRT could not be determined for majority of patients, and therefore we could not assess the relationship between the timing of doses and neonatal mortality, and the cause of death of the neonates could not be determined. This was also a single-site study at a university-affiliated tertiary-level institution, and therefore the results may not be generalizable to other hospitals in Jamaica. So in conclusion, a higher proportion of neonates who received SRT compared to neonates who did not receive SRT during the study period died. However, neonates in the SRT group were clinically more unstable at birth, smaller and less mature than those who did not receive SRT, and significantly higher percentages of bronchopulmonary dysplasia and ROP were observed in the surfactant group. Our recommendations include establishing a surfactant registry to determine factors related to SRT administration, prospective studies to explore factors that impact mortality and long-term morbidity in preterm neonates with RDS, and establishing NICU protocols for early rescue surfactant administration based on objective criteria. I would like to thank everyone as shown. Thank you. These are my references.
Okay, so I guess you all will all agree that our first session was excellent. And we are gaining, yes, Scap. So I would like to invite the three presenters, to have a seat. Don't be shy. And I will now open the floor to any questions. We have, one mic is working. Okay, so any questions?
Thank you. Presenters, yes, the overall presentations are very well done. So I have a question for each of you, and I'll just give the questions and then you can handle them for me. So for Dr. Beckford, very nice on the data that you gave and, explaining that your results are not generalizable. I noticed that your percentage was close to the data from 2010 study, which I think was KPH. Was here as well, okay. So I was just wondering if you had any idea of the profile of where the patients come from for Spanish town. I know you said it's not generalizable, but I'm curious in terms of the population that is actually covered. So that's your question, whether it's just Spanish town or do they come from Portmore, etc. So that's a question for you. But Dr. Dawkins, forgive me here, my epi is not so strong. But I was just wondering, are you sure that you calculated incidence, not prevalence? So if you could just go through that and clarify whether it was incidence. And then for Dr. Allen Bryan, I was just wondering, your data was actually quite interesting, but I didn't see any comparison in terms of those factors that you did find significant, such as BPO and ROP. I was wondering how did your data compare to what is out there in the literature as it relates to that? So.
Hello. Hi, Doc. Thank you for that question. In terms of population, the parish of St. Catherine serves other parishes such as Kingston and St. Andrew, St. Mary, Clarendon, St. Anne. University Hospital of the West Indies will primarily serve Kingston and St. Andrew with patients from St. Thomas and pretty much any patient from Jamaica, since it's a tertiary hospital. Now, we said that the study might not be generalizable to all institutions, but we do recognize that our patients and the University Hospital patients would be similar in terms of location. And to also remember that Spanish Town Hospital refers patients to the University Hospital.
Okay, hi, thank you for that question. From my understanding, incidence rate would have been any new cases that would have been identified during the study period. And for ROP, that would have been a new condition that would have been developed by the infants during the time. So I think it would be incidence rates and not prevalence. Okay. I thought that because we were looking in that moment in time, we're just looking at the new cases that would have been developed during that time. And so hence why we use the term incidence instead of prevalence.
Good evening. Thank you for that question as well. As it relates to how the rates of BPD and RP compare, what I found was that if we compare to developed countries, our rates are actually much higher for both BPD and ROP, but compared to lower and middle income countries, they were similar rates. Oh, so the difference between the groups, I did not find for developed countries, but there was at least one study, I believe in India, where they found a difference. The babies who got surfactant had a significantly higher rate of ROP, and none of the babies in the comparison group had ROP. For bronchopulmonary dysplasia, I'm not sure.
Thank you. I'm going to ask you all at the end. I imagine I am the editor of the Journal of Pediatrics. The question I'll ask at the end is, why should I accept your paper in my journal? Okay? And I want to. The questions I'll ask though is for Dr. Beckford. You said that there was a study was done at the University Hospital, but none at the Spanish Town Hospital. Is there any hypothesis why these two settings should be different? And why repeat the study at Spanish Town? Because I'm going to ask that as editor. Please answer that question. Yes. Oh, you need the mic? There's only one mic here. Yes. I do have to speak into the Canada show. Oh.
Hi, sir. Thank you for that question. So the University Hospital of the West Indies, a tertiary institution in Jamaica, in terms of its pediatric service, it offers specialist services. The Spanish Town Hospital, a type B hospital, which is a public hospital. So with one being a tertiary hospital and it's more semi-private, and one being a public hospital, we can see that invariably they will have differences in terms of resources in what is available to them. So in reality, we can't exactly compare both institutions. What we could compare our institution with Victoria Jubilee Hospital. An unpublished study was done there, but also to bear in mind that our neonatal unit at the Spanish Town Hospital compared to Victoria Jubilee Hospital would just in recent times have access to mechanical ventilators. So when we were presented with patients who required with a very low birth weight infants who would require more invasive respiratory support, we would have to transfer these patients.
Would I, as the editor, know all of this you just told me from your presentation? Would I know this from your presentation, all you just told me? And
it is in addition to the presentation.
Yes, indeed. And while you're there, tell me why I should accept your paper for publication.
Why I should accept my paper for publication? Well, the Spanish Town Hospital, as I said before, it's it's the largest type B hospital in Jamaica. It serves a wide population. It actually sees a lot of patients per year in terms of deliveries compared to the University Hospital of the West Indies. It will give a more representative background or foundation of what the very low birth weight mortality rate is in Jamaica.
Thank you.
You're welcome.
Dr. Dawkins, let me go quickly since I don't want to hog the show. Trying to read this. You said there was no data from Jamaica on ROP. Okay. And you also said that the trend seen in developed countries was reversed in the lower and middle income countries. Did I get that right? Okay. In your discussion, you can stand at the mic, please. In your discussion, I don't remember seeing data on a comparison of your findings with other settings. Was that there on a slide, or did I miss it?
Okay, thank you for that question. So yes, I did mention it. So our incidence rate in our very low birth weight babies, I had said was 45.7. Initially, I had listed some other countries, so we compared it to incidence rate there's a Brazil study that showed an incidence rate of 33.2%, one in Nigeria that had about 32%. And when you compare it to the developed countries or the upper income countries, we're looking at 15%.
Okay, so
incidence rate.
I'm going to hurry things along. Sure. Did your discussion look at the particular factors which would have given you these comparisons, or you just look at the overall figures and say this is close to Cuba or Nigeria? Were the factors similar in your study to these?
The factors were similar. So in all the studies, or majority of the studies that I looked at, birth weight and gestational age were always a risk factor.
Last thing is I think, tell me if I got this wrong again. You said completeness of screen, that in your study, you had 26%, Nigeria had 87.3%?
No, so our study, only 87.3% of patients completed screening.
Right. And in Nigeria,
they had
26%.
26% lost the follow-up. Yes.
Okay. And what was the driving force behind those numbers? And why should I publish a paper?
Okay, so in Nigeria, they had similar settings to ours. So their hospital had no ophthalmology service available. What we noticed too from our study is that because these patients are discharged from hospital and now have to go to another institution to receive ophthalmology care, we lose a lot of them to follow up. And so that's something that we want to address to hopefully decrease that number. So hence why we had recommended having a visiting ophthalmologist or having those tracking systems in place to keep track of these patients. And why you should choose my study, we really have not looked on ROP a lot in Jamaica. I think my study definitely gives good information on the incidence or prevalence of ROP at Spanish Town Hospital. Spanish Town Hospital, as Dr. Beckford says, sees a lot of patients yearly. And so therefore, I think it would add additional information.
Thank you.
Thank you.
And quickly now, Dr. Brian, you started off in your background by saying there was no difference in the outcomes at UHWI. And at the end of the talk, I wasn't sure why, because you seem to find so many different outcomes. And why should I publish a paper? Thank you.
Okay, so the previous paper had looked at babies from the period 2001 to 2011. And in this study, about 75 neonates received surfactant. Overall, though, over 300 babies had been diagnosed with RDS and only 13% received surfactant. One of the limitations of that study was the cost of surfactant and the accessibility of it. And so since that study ended in 2011, and we had not looked at this topic for 10 years, we thought, as well as the fact that surfactant is more accessible now at the UHWI, we thought it would be good to take a second look to see what the outcomes were in terms of death being the primary outcome, and why you should publish my study. So this study is, though there were a number of limitations, it's highlighting, it's getting the conversation started as to why our very low birth weight babies, because those were the majority of the patients who died, why are they the ones getting surfactant dying? Why is the mortality rate so high in these patients? And so it will start the conversation of what do we need to do? Let's review. How are we administering surfactant? What's the timing like? Are we giving it as early rescue therapy versus delayed? And how will these factors impact on mortality when we look at future studies? Thank you.
I've got a quick question, Professor Trotman. This will be quick. Over here to your left. Thanks for this, guys. Really great work. Question to Dr. Dawkins. I really liked your recommendation of a tracking system to assist with follow-up of patients who tend to get lost in the system. Can you expand a little bit on what that tracking system would look like? And then to Dr. Alan Bryan, I think you've just identified another study looking at the timing of surfactant administration and the relationship to outcomes. Thank you, guys.
Okay, so in terms of the tracking system, what I was considering was to have, so AAP actually has recommendations for cases like this. They recommend that any baby who their retinal development is not complete, that we need to organize and ensure that that first follow-up visit is organized before they leave hospital. We want to ensure that we have the numbers for the parents, that we call them regularly to ensure that they meet these follow-up dates. We had also a high loss to follow up for the patients coming back to Spanish Town, which the Spanish Town Hospital should be their medical home, especially for these premature infants. And so we want to ensure that we can get these patients back to follow up. That way we can ensure that they're actually going for their eye care at Bustamante. Thank you.
Okay, so I'd like to thank our presenters as we move in. And just for clarification, I just want to say that from my understanding, or Dr. Dawkins may not be aware, it's very long ago, but we had an ophthalmology who had looked at ROP, but it's unpublished. And that data is not available widely. But I do know at the University Hospital, Dr. Zoe Winter had done an unpublished study, and one of our previous residents had also done an unpublished study. So just for clarification. So we go into our session 2, and I'd like to invite Dr. Dean to come and tell us about SLE at the Bustamante Hospital.
Good afternoon. My name is Sanjay and Dean. I have the pleasure of presenting my research topic today. Hearing me clearly? Hello? Great, okay. Good afternoon. My name is Sanjay and Dean. I have the pleasure of presenting my research study. It's titled A Review of the Pattern of Disease Manifestations, Disease Activity and Outcomes in Pediatric SLE at a Pediatric Referral Center in Jamaica. My supervisors were Dr. Sandrika Young-Peart and Dr. Peter Gay Scott Brown. So systemic lupus erythematosus is an autoimmune condition, and it often follows a relapsing and remitting course and may progress to irreversible organ damage. So we looked at the literature and we reviewed studies. All these countries highlighted in red, we looked at data from those locations. And when we reviewed the literature, we noted there was a paucity of data from the English-speaking Caribbean, and there was no research published from Jamaica. So this is just highlighting a few of the things we noted. And we noted that SLE in the pediatric population followed a more aggressive course, and they had higher incidences of end organ damage and higher SLEDAI scores at diagnosis. So our aim was to describe the presentation of pediatric SLE and document disease severity and outcomes at a year post-diagnosis. And specifically, we wanted to document the clinical and laboratory features at presentation, the SLEDAI scores at diagnosis, and to document the SLEDAI, SLIC ACRDI scores and the outcome at a year. So I've introduced 2 scores. The SLEDAI 2K score that stands for the Systemic Lupus Erythematosus Disease Activity Index. And it's a standardized scale used to evaluate the activity of the disease over the preceding 30 days. And it looks at weighted clinical and laboratory criteria. And it's used to classify the data in terms of no disease activity, mild, moderate, high, and very high disease activity. And the SLIC ACRDI score is a damage index created by the Systemic Lupus International Collaborating Clinic and the American College of Rheumatology to determine end organ damage in the disease, which may be related to the disease itself or to the treatment. So we looked at children diagnosed with systemic lupus erythematosus between January 1, 2013 and December 31st, 2022 at the Bustamante Hospital for Children. And it was a retrospective study, and we looked at the participant records, collected data using a digital extraction sheet, and we analyzed the data using IBM SPSS suite of software. And of course, we would have gotten ethical approval from the MONA Research Ethics Committee, as well as the Southeast Regional Health Authority. So what did we find? We had 11 participants, 91% of which were female and 9% were male. And our mean age was 10, and our participants ranged in age from 6.8 to 11.6 years. This slide highlights the clinical features, with presentation being in orange and at diagnosis being in green. And our study noted that there was a significant prevalence of constitutional symptoms in our cohort. 81.8% of our patients experienced fever, and 63.6% of our cohort experienced lymphadenopathy, anorexia, and weight loss. When we looked at diagnosis, we note that by that time, 72.7% of our cohort experienced pericarditis, 54.5% experienced proteinuria, and 27.3% experienced pleuritis. And when we looked at the work that we reviewed, the most common features were fever, malar rash, and renal manifestations. Lymphadenopathy is not a part of the criteria for SLE, and was documented in 2 studies, and its prevalence ranged from 6 to 19%. Serositis was another feature that was infrequent, and in the literature ranged from 24.8 to 32% of those cohorts. When we looked at the laboratory features, ANA was positive in 100% of our cohort. 90.9% of our cohorts had qualitative anti-dsDNAs that were positive, and 90.9% also had anemia. Of those who had the anti-Smith done, which was 3 patients, all were positive at 100%. Of those who had C3 done, 70% had a low value, and of those who had C4 done, 83.3% had a low value. Significantly, when we looked at the literature, anemia was only present in 16.1 to 75.8% of the cohorts that we reviewed. And so the prevalence of anemia in our study was an outlier. We had 5 participants in our study who experienced renal manifestations and as such had renal biopsies done. And when we looked at that, we noted 2 patients had class 2 nephritis, 1 participant had class 3 nephritis, and 2 participants had class 4 nephritis. Reviewing the literature, class 3 nephritis was most common in Singaporean and Egyptian studies, affecting up to 42.5% of those cohorts. And class 4 nephritis was most common in Brazilian and Malaysian cohorts, affecting up to 54.3%. But class 2 nephritis was infrequent in all the cohorts we evaluated, between 13 and 23%. When we looked at the SLEDAI scores at diagnosis, our mean score was 17.55, and it ranged between 6 and 42. And we noted at diagnosis that majority of our patients experienced high disease activity or very high disease activity. At a year post-diagnosis, our mean score would have improved from 17.55 to 4.71. And that's in keeping with the research that we looked at, where at a year, most of those studies documented improvement in scores. And majority of our patients would now be experiencing no disease activity or low disease activity. When we sub-analyzed our SLEDAI 2K scores, we noted that for all groups, the entire cohort, our mean was 17.55. And we noted for those who had no major organ involvement, specifically not experiencing lupus nephritis or neuropsychiatric lupus, that our scores were lower at 9.8. The highest scores noted among patients with neuropsychiatric lupus, and high scores amongst those who had lupus nephritis. We did not have any patients who experienced both lupus nephritis and neuropsychiatric lupus. And this was in keeping with Hiraki and his Canadian cohort, who also noted that those who did not have major organ involvement had lower scores than the mean. At the 1-year mark, we had 7 participants remaining, and 3 of those patients experienced end organ damage with a score of greater than or equal to 1 on their SLIC ACR-DI scores. 1 patient having cardiovascular manifestations, having experienced pericarditis for more than 6 months. Another experiencing renal manifestations, a GFR of less than 50. And a 3rd patient who had ocular manifestations as optic atrophy and neuropsychiatric manifestations, having seizures for in excess of 6 months requiring therapy and cognitive impairment. Looking at the research, the most common manifestations at a year were ocular, neuropsychiatric, and musculoskeletal, and renal and cardiovascular manifestations were relatively rare, affecting less than 6% of the cohorts that we reviewed. In conclusion, constitutional symptoms were the foremost feature prompting evaluation. And in an early and middle childhood Afro-Caribbean population, constitutional symptoms should arouse a high suspicion for SLE. In this population, a screening echo, formal urinalysis, and a spot urine protein creatinine ratio may identify pericarditis and nephritis prior to overt manifestation and improve our time to diagnosis. In the evaluation of a child with constitutional symptoms whose initial evaluation does not show lupus, there is room for serial review and repeat laboratory investigations. Our study was limited. The Bustamante Hospital for Children is the only pediatric hospital in Jamaica and in the English-speaking Caribbean. However, it serves children up to their 12th birthday. And so children 12 to 18 years with pediatric SLE were not included. It was retrospective, which has inherent limitations, including missing data. And there were 3 records which could not be found for evaluation for our study. We had a small sample size, a total of 11 patients. Some investigations, specifically complement and quantitative dsDNA, are used in the evaluation for the SLEDI 2K tool. Those are not available in the public system. And so for our cohort, all SLEDI scores are considered to be minimum because they could not be completely evaluated in all cases. We recommend lobbying Jamaica's Ministry of Health and Wellness regarding addition of complement, quantitative ANA, and quantitative dsDNA and anti-Smith to the public offering. These investigations are important parts of diagnosis, but also monitoring, and may help to guide therapeutic interventions. We recommend educating healthcare practitioners who care for patients with SLE on the SLEDI 2K tool. And this may improve the ability to identify increasing disease activity and escalate therapy. Thank you.
Thank you, Dr. Dean. We'd like to welcome Dr. McIntosh to tell us about congenital heart disease at the Spanish Town Hospital.
Good evening, everyone. I'm Nareet McIntosh, and I'll be sharing with you my research project entitled The Birth Prevalence, Echocardiogram Findings and Outcome of Congenital Heart Disease and Critical Congenital Heart Disease in Infants Born at the Spanish Town Hospital. Principal investigator was Dr. Tracy James Powell, and our co-investigators included Drs. Bavette Butler, Jacqueline Wright James, and Dr. Oluwayomi Olugwe. Congenital heart disease is a malformation caused by the abnormal embryologic development of the heart and the large blood vessels. It's the leading cause of death of all congenital anomalies. 1 in 4 congenital heart disease is a critical congenital heart disease. This means that early surgical intervention is required for the neonate survival. Congenital heart disease can be classified broadly into acyanotic and cyanotic heart defects. The cyanotic defects highlighted here formed the critical congenital heart defects explored in our study. The Sustainable Development Goal 3.2 aims for a neonatal mortality rate of less than 12 per 1,000 live births by 2030. And though prevalence of congenital heart disease varies globally, early diagnosis of CHD, especially CCHD, may contribute to a reduction in neonatal morbidity and mortality. As the outcome depends largely on timing of diagnosis, it's important to have a fetal echocardiogram done prenatally as indicated, and pulse oximetry screen and transthoracic echocardiogram done postnatally. There's literature describing congenital heart disease and critical congenital heart disease in the United States of America, United Kingdom, Canada, countries of West Africa. However, there's marked paucity of data on hospitalized infants, especially in Jamaica. The aim of my study was to describe the birth prevalence, echocardiogram findings, and outcome of CHD and CCHD in infants born at the Spanish Town Hospital from January 1, 2020 to December 31, 2023, and to highlight the demographics of these infants. The primary objective, therefore, was to describe the birth prevalence, echocardiogram findings, and outcome of CHD and CCHD in these infants, to describe the maternal and neonatal demographics, and to compare the birth prevalence of CCHD found in this study with those generally quoted prevalence worldwide. This was estimated at 27.8 per 10,000 live births. This study was a descriptive retrospective cross-sectional study that took place at the Spanish Town Hospital. It is the largest Type B hospital in St. Catherine, and it has a special care nursery, a neonatal high dependency unit, and is headed by a consultant neonatologist. Pulse oximetry screening is documented, should be documented on all patients born at the Spanish Town Hospital as per the hospital's policy. We do not, however, provide echocardiographic services. This is provided by the Bustamante Hospital for Children, or may be done privately by a trained pediatric cardiologist. 210 patients were identified from nursery admissions logbook using key terms such as cardiac murmur, congenital heart disease. And of these patients, 101 were excluded, for example, due to no echocardiogram being found in the dockets or some of the dockets not being able to be located. We were left with 109 patients who had echocardiogram reports. However, 26 were excluded as their echo reports only showed an isolated patent foraminovale, which is not considered a congenital heart disease. 83 patients met our inclusion criteria. They were entered into the study. Their dockets and echo reports were reviewed and entered into an electronic data collection sheet, which was then analyzed descriptively using the STATA statistical software. We found a birth prevalence of congenital heart disease of 46.7 per 10,000 live births and a birth prevalence of critical congenital heart disease of 2.8 per 10,000 live births. The median time to diagnosis from birth to echocardiogram in this study was 35 days for congenital heart disease and 4 to 5 days for critical congenital heart disease. Our study had a male preponderance in terms of distribution of sex and a mean birth weight of 3.02 kilograms. The mean gestational age for females was 36.6 weeks and 37.9 weeks for male, which was statistically significant at a p-value of 0.03. The mean maternal age was 35 years old, and the two most common maternal chronic illnesses identified were hypertension and diabetes, accounting for 37.1% and 25% respectively. The most common presenting symptom was fast breathing, and the most common presenting sign was a cardiac murmur, which accounted for 65% of the total study population. In terms of what we found on echocardiography, the most common identified acyanotic heart defect, or the non-critical heart defect, was an atrial septal defect. And the most common identified critical congenital heart defect was hypoplastic left heart syndrome. This accounted for 2.4% of the study population. In terms of the outcome, none of the patients with the non-critical defects died. However, 2 deaths were reported from the study with critical congenital heart disease, and both these patients had hypoplastic left heart syndrome. They died at age 6 and 7 days of life. Our study found a birth prevalence of 2.8 per 10,000 live births versus globally quoted prevalence of 27.8 per 10,000 live births, with an incidence rate ratio of 0.1, which was statistically significant. Why was this so? So we thought the lower prevalence may be due to issues with detection rate for congenital heart disease at Spanish Town Hospital. Many of these cases may be missed at birth because they may have confounding clinical presentations, or they may have non-classic symptoms and signs. Additionally, some patients may not have had an echocardiogram as they may have been unstable for transport to a tertiary medical facility where this service was offered. We also believe that there may have been some missed cases from lack of autopsies due to parental refusal, or there may be an alternate explanation for the cause of death, for example, overwhelming sepsis or prematurity, and these patients may not have had an autopsy. We also believe that there may have been underreporting as echocardiographic records of the patients included in the study only access the service publicly. So when compared to the previously published data, the neonatal demographics were similar in terms of gestational age, sex, and birth weight. We also found similar echocardiographic findings of critical congenital heart disease, where hypoplastic left heart syndrome was noted to be the most common critical congenital heart defect, and the heart defect that had the outcome of death. This study was not without limitations. It was a single center study, which speaks to the applicability or generalizability. There were issues with docket retrieval and documentation being a retrospective docket review, and there may have been missed cases as mentioned before. Of the list of recommendations, we found it important to highlight 2 main ones. We think there needs to be an on-site echocardiogram at all hospitals, which will help with providing ready access to these services, especially for patients who may not be stable or fit enough for transport to these other facilities. We also believe in an implementation and enforcement of a pulse oximetry screening protocol, which may be helpful to identify these critical congenital heart defects. In conclusion, the birth prevalence of critical congenital heart disease in this study, when compared to the global prevalence, may suggest an under-detection in this study population. We believe that measures are to be put in place to identify critical congenital heart disease, especially those in resource-limited settings, including low technology tools such as pulse oximetry screening. After implementation of these measures, we find that there is area for subsequent studies to be explored, and this may provide useful comparative data. Thank you.
Thank you, Dr. McIntosh. And now we welcome Dr. Hammond to tell us about newborn screening for sickle cell disease.
Good evening, everyone. The title of our research, an audit of the timelines for submission of sickle cell disease newborn screening and confirmatory samples to the Caribbean Institute for Health Research, CARE laboratory by the Northeast Regional Health Authority and Southeast Regional Health Authority, Jamaica. Principal investigator was Professor Jennifer Knight Madden, co-investigator Dr. Roxanne Melbourne Chambers, and myself as the DM candidate. Now, sickle cell disease is an autosomal recessive inherited disease that results in a majority of sickle hemoglobin, HbS, in the red blood cell. It may present during infancy and early childhood years with severe complications that can be prevented or attenuated by early diagnosis and treatment. The Jamaican sickle cell cohort study, initiated in 1973, was groundbreaking and demonstrated that sickle cell disease newborn screening could be undertaken on a public health scale. Sickle cell disease presents with complications in early life that will lead to significant morbidity and mortality if left undiagnosed and untreated. Now, King et al. In 2015 showed that the overall mortality of children less than 5 years old with sickle cell disease diagnosed by newborn screening and managed at a comprehensive care center was equivalent to the mortality in the general population. This demonstrated the need for early intervention and comprehensive care. Now, the aim of any newborn screening is to identify neonates and infants who are at risk of early complications and to prevent them. Newborn screening for sickle cell disease has been undertaken in most public hospitals in SARA since 1998, while those from NERA joined in 2015. Of note, Princess Margaret Hospital, also in SARA, joined the program in 2015 when NERA also joined. Now, the standard of care, sickle cell unit clinical care guidelines 2015, is that infants receive a conjugate pneumococcal vaccine by 8 weeks of life and begin penicillin prophylaxis by age 4 months in severe genotypes such as HBSS. Almost all babies who are born in Jamaica are screened for sickle cell disease. The newborn screening program does not seem, however, to be as efficient at ensuring early enrollment in a center of care for those identified. Ibar et al. In 2023 showed that only 40% of infants in Jamaica born between 2015 and 2017 with HBSS were enrolled before 8 weeks of age. There is therefore a need to identify steps that can be improved in the screening processes, hence the rationale for such an audit as we have undertaken. Our aim was to audit the sickle cell disease newborn screening and confirmatory sample submission timelines to the CARE laboratory by NERA and SARA from 2018 to 2022. Our objectives: in infants born at hospitals in these two regions, NERA and SARA, the objectives were primarily 1, to determine the interval between birth and time of arrival of samples for screening at the CARE laboratory for testing. 2, to determine the age at which confirmatory samples are received by the CARE laboratory. Secondary objectives were to determine the percentage of infants with samples that were consistent with sickle cell disease, and secondly, to determine the percentage of samples requiring confirmatory analysis which were received by the CARE laboratory. In terms of study design, This study was a retrospective record review that utilized the CARE sickle cell disease newborn screening database. The study population was all newborns who were born at hospitals within the NERA and SERA within the years 2018 to 2022, for whom screening samples were received by the CARE lab. The site of the study was the sickle cell unit, CARE, located at the UWI Mona campus. De-identified data from the CARE sickle cell unit sickle cell disease newborn screening database were extracted, with inclusion criterion being all neonates or infants who were born whose samples were sent for testing between 2018 to 2022. Data were stored on password-protected computers to which only researchers involved in the case had access. In terms of risk, this study presented minimal risk, as only de-identified or retrospective data were used, and there were no identified conflicts of interest. Now, what did we find? For the results, a total of 86,382 samples from both regions over the 5-year period were analyzed. As can be seen from the pie chart, samples from SERA represented 76% of the total, while those from NERA made up the remaining 24%. 931 babies who were missed due to unavailability of growth records for newborn screening at the time were removed from the dataset and analyzed separately. As the table shows, there was a significant difference in the age of infants when screening samples were received by the CARE laboratory between NERA and SERA. Although the median in both the regional health authorities was 6, NERA had a much wider interquartile range with longer intervals. 453 samples, or 0.52% of the total collected, were inconclusive and required confirmation to determine their true genotype, with 437 of them being unusable due to contamination with maternal blood and another 16 being insufficient to test. Of the 85,929 samples that had screening results, sickle cell disease accounted for 0.62%, which is consistent with prior prevalence studies in the population, while traits accounted for 13.6% and normal genotype accounted for 85.6%. Now, from this table, it can also be seen that there was a significant difference in the age of infants between NERA and SERA when confirmatory samples were received by the CARE lab. While the median for SERA was 70 days, that for NERA was 156 days with a wider interquartile range and longer intervals. Now, 623, or just about 62% of the 1,004 infants who required confirmation had a confirmatory test, with 560 being from SERA, while 63 were from NERA. Of these 623 tests that required confirmation, only 164, or just 26.3%, were done at or before 8 weeks of age. Now, having a confirmation test by 8 weeks of age was associated with having sickle cell disease, being born in a SERA hospital, and a lower age of arrival of screening tests to the lab. So as we discuss these results, the median age at which screening samples were received from both health regions in the study was similar. However, those from the hospitals in NERA had an age range of up to 1,548 days. Now, this is much greater than the age range of samples that were received from hospitals in SERA. The reasons for such significant differences in timelines were not explored in this study and do require or warrant further investigation. Similarly, the median age of infants when confirmatory samples were received from NERA by the CARE laboratory was more than twice the median age for SERA. Reasons for this are the newborn screening program at SERA predates that in NERA by almost 2 decades, 1998 for SERA versus 2015 for NERA. Also, the processes involved in the tracing of infants for confirmation differ between the regions. Now, comparing the processing of samples between the two regions, it can be seen that confirmation of samples from Victoria Jubilee Hospital, the University Hospital of the West Indies, and Spanish Town Hospital is a single step where only one or a single sickle cell unit nurse confirms those samples, whereas in Princess Margaret Hospital and in NERA, it's a 3-step process before the infant is actually traced. So having a single person responsible for tracing may be more efficient than a 3-step process. The prevalence of sickle cell disease was consistent with previous findings, approximately 1 in 162 in the population studies, and indeed Hanchard in 2005 showed that the prevalence of the sickle cell allele in Jamaica hadn't changed over the past 2 decades and is consistent with our findings. So in concluding, sickle cell disease newborn screening is efficient at identifying infants who require confirmatory testing for the disease. There were significant differences in the sample submission timelines for initial screening and those that required confirmatory testing between NERA and SARA. It was seen that by 8 weeks of life, only 20.9% of the samples consistent with sickle cell disease in SARA were confirmed, while just under 3% of those in NERA were confirmed by that age. We recommend, therefore, that there be a purposeful study of the processes between screening and tracing, which would help to improve and allow for a greater number of patients to receive earlier linkage to care. I thank you. Please.
Thank you, Dr. Hammer. And our next presenter will be online from the Bahamas, Dr. Megan Maples.
Good evening, everybody. 1 second while I just try to share my screen. Okay. Is everybody seeing my screen? And can you hear me properly? Yeah.
We can't see your screen, but we can hear you.
Okay, let's try again. Share sounds. Share. Okay, can we see my screen now?
Yes, we are seeing your screen now.
Thank you. So I'll start now. Good evening, everybody. My name is Dr. Megan Maples, and today I'll be presenting on a comparison of the health-related quality of life of adolescents with a chronic medical illness attending medical clinics in the Bahamas to those without a chronic medical illness. Well, first of all, I have nothing to disclose, and this will be the outline of my presentation today. Firstly, what is a chronic medical illness? The American Academy of Pediatrics defines it as a medical condition that is currently not curable and that has been present for at least 3 months. And internationally, adolescents with chronic medical illness experience significant morbidity. They have increased physical disabilities, heightened hospitalizations rates, heightened stress, they have missed school, which all affects their educational success, peer relationships, family dynamic, depression and anxiety, and just their overall quality of life. Interestingly, however, those studies differ from what we found locally as well as regionally. So locally in 2023, Claire and colleagues analyzed the quality of life of these patients, and regionally, Singh and colleagues in 2022 in Jamaica did the same. And they found that quality of life was not significantly affected by chronic medical illness. But internationally, that's why this study is so important, because chronic medical illness is shown to result in poor quality of life, and it therefore becomes a never-ending cycle. So at what point are we going to stop that? Are we going to wait until they're an adult and they have their mental health affected? Absolutely not. We're going to be advocates for our patients, and we're going to target it from the beginning. So the aim of this presentation is to assess the health-related quality of life of adolescents in the private and public health sector of Nassau, Bahamas, with and without a chronic medical illness, and to determine if a difference exists between the two. The objectives were to compare those two groups and the quality of life between them, and also to determine the socio-demographic factors of participating patients. This was an analytical cross-sectional study that targeted patients aged 10 to 18 between May 2024 and October 2024. There were two groups, those with chronic medical illness and those without. Those with chronic medical illness were sampled in specialty clinics, the private sector, as well as national health insurance, which is a government-funded outpatient health source. The non-chronic medical illness group was sampled in the private clinics, NHI, as well as public community settings. The sample size was calculated using Rao-Soft, using a 95% confidence level, 5% margin of error, and a 50% response distribution, which equated to a sample size of 228 participants, and an equal sample size of those without chronic illness were also questioned. The inclusion criteria included those who were English-speaking as well as literate, and then we sampled patients aged 10 to 18 who were being followed up in the private and public sector. We excluded individuals that had illnesses lasting less than 3 months, had a self-diagnosis, or for example, were diagnosed already with a depressive condition. The questionnaire had two parts. Part A were socio-demographic factors, for example, how old you were or what is your gender. Part B was the pediatric quality of life questionnaire, which is a 5-minute, 23-item questionnaire with good internal reliability. Authorization was obtained to use the same, and grading was done on a 5-point Likert scale and analyzed 4 quality of life domains. The first is physical functioning. For example, it asked the patient, how hard is it for them to run? The second was emotional functioning. For example, it asked them how often they feel afraid. The third being social functioning, how often they get teased by their peers. Then lastly, we have school functioning, and it would ask, for example, how often they forget things. We used non-probability convenience sampling. Ethical approval was obtained, as well as approval from the relative administrators of the hospital. There was informed assent and consent that was obtained from each patient. Once we had the data, it was reverse scored. So for example, if they've answered a 4 on the Likert scale, that equaled a 0. And if they answered a 0 on the Likert scale, that would equal 100. 100 being the highest quality of life and 0 being the lowest quality of life. This data was then entered into SPSS, and the socio-demographic factors were extrapolated into means, percent total, and then crowding index was calculated. The CMI group was compared to the non-CMI group, for example, with an independent t-test. Now, in relation to the socio-demographic results, on the left-hand side, we have our chronic medical illness group, and on the right, we have our non-chronic medical illness group. The age was similar between the two groups, between 13 and 14 years. In relation to gender, both groups had a larger proportion of males, with number of 199 for chronic medical illness and 122 for non-chronic medical illness. For parental marital status, we can just follow the stars. So for chronic medical illness subgroup, the majority of the parents were single, while for the non-chronic medical illness subgroup, the majority of parents were married. For the chronic medical illness subgroup, the crowding index was higher than the non-chronic medical illness subgroup. This bar chart here shows the number of participants with each illness. You see on the x-axis, we have the 10 illness subgroups. The largest proportion was asthma with 42%, and the smallest was 2.6%. Here we start with the bulk of the pediatric quality of life questionnaire. So this table on the left, we have the 10 illness subgroups. In the 2 middle columns, we have the quality of life score. And on the right, we have the p-value. So let's just take it section by section. So those without chronic medical illnesses had a high quality of life score of 91. But when compared to those with chronic illnesses, the with chronic illness group had a significantly lower score, especially those with asthma and rheumatic conditions. But it is important to note that all of the illnesses had significantly lower scores. Now on to physical functioning. The without chronic illness subgroup had a high score of 96, and all illness subgroups were affected besides autism and ADHD. The lower scores, or the lowest scores I should say, were in asthma and rheumatic conditions. For emotional functioning, those without chronic illness had high scores of 89, and all illness subgroups had lower scores besides ADHD. with HIV, patients with HIV having the lowest scores, a score as low as 32. For social functioning, there were high scores for the without chronic illness subgroup with scores of 88. And all illnesses in this social functioning score were significantly low, especially those with autism. For school functioning, those without chronic illness had a high score of 91. And all illnesses were affected besides that were of seizure disorder, with rheumatic conditions being the lowest. So in summary, overall, the health-related quality of life was significantly impaired in those with chronic medical illnesses compared to non-chronic medical illnesses. In regards to emotional health, all subgroups had lower scores besides ADHD, with the lowest scores being those with HIV. For social functioning, all groups had low scores, with autism being the lowest. And for physical functioning, all groups had low scores besides ADHD and autism. And for school functioning, all subgroups had low scores besides seizure disorder. So in relation to comparing it to other studies, we mentioned earlier that locally and regionally, there wasn't a difference, and that is different from our findings that we found with this study. Our findings agree more with international studies. So for example, Pinkart and Tubert in 2012, they found that those with chronic medical illnesses had decreased physical functioning, social functioning, and emotional functioning. Lachman in 2021 found that school functioning and social functioning was significantly affected. And they also went into why. So they found that patients who had chronic medical illnesses had heightened pain, exhaustion, they experienced ableism, they had anger and resentment towards having their illness, and they also felt helpless. But it is important to note that there are protective factors. Harrison and colleagues in 2023 in South Africa found that peer support groups in those with HIV led to higher resilience, better attitude towards their illness, and higher psychosocial scores. So moving forward, this study did change the information that is available in the Bahamas. So research is needed into the risk factors and protective factors for our patients, and also adding routine quality of life screening into each health visit. This will allow for targeted, individualized assistance, and which will affect long-term outcomes of our patients. Limitations of the study. Firstly, illness subgroups weren't comprehensive. For example, we didn't include cerebral palsy. The chronic medical illness group was not matched with the non-chronic medical illness group, and there was a possible difference in economic status between each group. The strains is a large population size, and this is groundbreaking for the Bahamas and forms a foundation for future research. In conclusion, adolescents with chronic medical illness have poorer health-related quality of life in at least 2 domains affected, and future interventions and research is needed to improve long-term outcome of these patients. These are my references. Thank you very much.
Thank you, Dr. Maple. I'd like to invite all the presenters to come front. And Dr. Maples, please stay online.
Yes, ma'am.
I'll now open up the floor to questions.
Before views on duty.
Oh, Lord. All right, good. So enjoy the presentations. Starting to get a little saturated, you know. So I'll start with Bahamas. I think I might have missed your objectives because I think you started with private and public, and you had similar numbers from each group. But and I'm sorry we didn't have the abstracts before to at least review. So if you could maybe just remind me what your objective was, because I think I missed something there, and unfortunately I don't think I have any questions because I think I got confused with your numbers from public and private. But if you could just remember what your objectives were.
Of course, thank you for that question. So the first objective was to analyze the health-related quality of life in individuals with chronic illness and without chronic illness in 4 subgroups, that being the physical, social, emotional, and school functioning, and to compare the 2 groups. The second objective was to determine the socio-demographic factors of the participating patients.
Right, so you got 228 from private. and 228 from public.
The non-chronic medical illness subgroup was sampled in multiple different clinics. So private as well as NHI, which is a form of public health care. And then the chronic illness subgroup was sampled in our specialty clinics, as well as the private clinics, as well as national health insurance clinics.
Okay. I wasn't so sure the sampling would actually, confirm what your findings are. So I'm a little concerned about that, but I'll probably leave that question to be addressed by someone else. Dr. Hammond, I'll just ask for the rest of us to ask questions and then you can address it. And perhaps we should just use that mic since there's only one here. Dr. Hammond, I got a little lost with yours because I was surprised 931 data was missing. I thought we had perfected the screening of newborns, and I wondered, I was a little concerned about that large number. The reality is that we have a number of children out there who have really not been screened at this time in Jamaica. I just wondered your thoughts a little bit on that. I mean, are we doing anything to correct that?
Okay, thank you for that question. So that number actually represented a period where there were missing good records for screening. So it was between January 1st, 2018 to March 31st of 2019. So those would have arrived significantly later to be outside of our study period. So this does happen still. But that was a particular issue at that specific period of time.
Oh, so there is no intention of
the resources. Right?
Oh, so we're really not on top of it when it comes to screening in Jamaica.
We are on top of it. Otherwise, I do believe from our data.
Okay.
That only represented a small percent.
I want to ask him?
Yeah. No, it's while you're there, doctor. I'm going to ask one question of everybody. I want you to tell me very briefly what is so novel about your study that I should accept it in my journal.
Okay, thank you. So you should accept our study for publication because as an audit, it's actually a baseline audit. No other study has looked at auditing the timelines before in terms of sickle cell newborn screening. I think it's pioneering, and so it would lay the groundwork for much further studies to be done.
Thank you.
All right, Dr. McIntosh, you gave a global prevalence of 27.8 for every 10,000 for your condition of interest. And I don't think I saw the reference. And I was a little worried about you using that figure because if it's a global, I mean, I would think that maybe at this, segregation of the data in terms of high income and low income would have better informed your study. So I don't know if you have those figures, if you would like to tell us about that, especially since your value came out to be like 46.7. So, maybe you would like to have a little discourse on that and tell me where you got that figure from. Is it really relevant to our setting?
Sure, thank you for the question. The global prevalence, the figure that we came up with was from a study by Bakker et al. In 2018. It's a retrospective international cohort study, and they basically used 15 health surveillance programs. And this included the birth defects among countries, North America, South America, Latin America, West Africa, and Europe. So we found that the prevalence, everything that we got from that study, it would have been a bit reflective since we have something globally, but there was nothing particular to the Caribbean. So that's why we thought as a rationale to do something.
And no other middle income country data?
A part of some of the countries in Latin America were regarded as middle income. So it was appropriate, we thought, for this presentation.
Yeah, I think that's where Jamaica falls now. So I'd have liked to see that filter.
Okay.
I'm curious, more males and females?
So the males in the neonatal period tend to be the tricky ones. They are usually the sex that is seen with the increase in mortality as it relates to the chronic illnesses. So necrotizing enterocolitis, respiratory distress syndrome. So it wasn't surprising that the males came up as the more prevalent sex in this study.
one of the things that stood out for me was time to echo. Could you comment on that again for me, please?
So the time, sorry?
Yes, I just want to reiterate the significance.
The time to echo for those with congenital heart disease was 35 days. The time to, that is from birth to echo, and the time for critical congenital heart disease was about 4 to 5 days. And this is usually because some of the patients who have congenital heart disease may present with rather nothing very overt. They may actually be okay until the physiology in terms of the circulatory system, they actually start to show symptoms. And so those persons tend to present later and they may have an echocardiogram done later. However, those with critical congenital heart disease may have more severe symptoms and at that time presenting with cyanosis, etc. And we tend to pick those up a little bit earlier.
And what is the most novel thing in your study to get it published?
Okay, so I think as an aspiring pediatrician, one of our roles is advocacy. A role that I think is important and one that I'm strongly advocate for.
Did you study advocate study?
In medical school.
But is this an advocacy study?
It's not, however, I think the findings of this study that showed how different it is in terms of the gaps in detection with a resource limited setting, it's very important to realize that there are some ways that we can implement measures to actually reduce the mortality that's associated with critical congenital heart disease.
Thank you.
All right, thanks. So, Dr. Dean, that's where we are, no? Yes? All right, so my question to you, and I want to commend Dr. Maples, because she's the only one that actually provided us with a sample number calculation. And I know you had to do it for ethics. All of you had to provide some kind of sample number calculation. And I think it's very important for Dr. Dean, because yours was what, 11? I would really not want to kind of match anything there with 11. And it's always misleading when you give these 80% and 90% when it's like 5, 6. So I'm a little concerned about it. And I wondered what was the actual calculated sample number that you had projected to get? And perhaps, it would have been nice to help your aspiring students in PG3 who are looking projects. I mean, to give them some recommendation to take this on and finish it, or is it not worth it because you're not going to be able to calculate or attain the numbers that you had expected?
Okay, thank you for that question. When we were preparing the proposal for this research based on systemic lupus erythematosus being a rare disease and also being a rare disease in the pediatric population, when we attempted to do sample size calculations, they weren't significant. So we actually had not included a sample size as part of it, especially since we were also doing an epidemiological study.
Well, that's good. That's fine. So you could have actually done some calculations based on your figures and at least inform the next person in terms of what kind of numbers they would need to power the study.
Dr. Dean, I want to come to your defense to say that in some cases, this is pediatric SLE, which might not be very, very common. However, your findings can inform larger studies and definitely should be published. When I had black hair many, many years ago, Professor Wilkes told me that HDLV1 was described through a series of case reports. So people like me who are lab scientists, we don't publish case reports and we frown upon them. And he explained the importance. So, but tell me, what is so novel about your study that it should be published?
Okay, so I think this study warrants publishing. Looking at the data, there is not much from the English-speaking Caribbean, and the last study was actually from Trinidad over 10 years ago. And looking at our data—
What was this sample size there?
34,
yes.
I believe. And then also looking at the findings that we noted, lymphadenopathy and serositis being so prevalent among our population and not previously reported in other studies. I think there's role for particularly prospective studies looking at lymphadenopathy specifically. In adult populations, they noted lymphadenopathy to be present in up to 33%, and it's associated with higher levels of hypocomplementemia, disease activity and accumulation of damage, and it would be worthwhile to see if that is present in the pediatric population as well.
Thank you. And Dr. Maples, not to drag this thing on, but what is so novel about your study that's worth publishing?
Yes, thank you for that question. So first point, the results of this study are groundbreaking, and the information needs to be known, not only to make changes in the hospital, but also on a government level to help our patients. Secondly, this research paper is already one step closer to publication because it already fits the strobe checklist.
Evening. Thank you for your papers. Dr. Hammond, it seems we do have the initial screening down pat, but from your paper, I'm gathering that we actually need a proper protocol for the confirmatory screening. I saw your recommendation that a single person do it, but what is your standard? What is your target timeline? We get that it's taking long in NERA more than it's taking long in SERA, but how long should it be and who should initiate it in your view?
Okay, thank you, Dr. Donis. So the standard is we actually would want everyone to be confirmed at or before 8 weeks of life in order for them to be attached to a comprehensive, a center of care, in order for initiation of care to be implemented. The standard of care is for penicillin prophylaxis as well as pneumococcal vaccines to be initiated as early as possible. So we do want, ideally, for everyone to be identified, traced and followed up, and attached to a center of care by 8 weeks of life.
Okay, so I'd like to thank the presenters for this section. And now we move into refreshments. Oh, sorry, I'm reading the wrong part of it. Just kidding. We now have a presentation by one of our sponsors.
Shall I greet them now?
They will be switching it.
Good evening, ladies and gentlemen. We extend our appreciation to you for having us to participate in your Child and Adolescent Conference this evening. Thanks for allowing us this opportunity to highlight our products and give you some pearls and some little overview on these products, which I'm sure all of you know them very well and had them to your armamentarium for many years. But it's a pleasure to be here to present to you again. Thank you. And my colleague here, Shannon Gibson, lovely Shannon Gibson, she will be presenting for us this evening. I'll just stand and support her.
Good evening again, everyone. Thank you for having us be a part of this forum. It's been very nice, and we hope that we can partner with you going forward. So let's jump right into it. We're doing a spotlight on the Leo portfolio. Myself, Shannon Gibson, and Mr. Linval Ford, we are the medical representatives that represent the Leo portfolio, right? All right, so starting off with the fusidin line. So the fusidin line contains your fusidic acid, right? And it's bactericidal, it's a bactericidal topical antibiotic. And we have a wide range of presentations. So your fusidic acid is going to be giving you penetration down to the deepest layers of the skin within 30 minutes, right? And it's not inactivated by any pus, blood, or enzymes. It also is giving you this penetration across any skin condition. So whether it's intact, damage, or avascular tissue. And again, to underscore that you're getting this penetration within 30 minutes. So we have a little comparative diagram here that compares with some of your other common topical antibiotics. And for instance, you're getting 2% total dosage absorption across intact skin with your fusidic acid, as compared to your mupirocin, where you're getting about 0.24% absorption. So that is pretty significant. And that is definitely why we get some of the excellent results that we do, even in some of your more resistant infections. So in terms of presentations, we have your fusidin cream, and that is more of an aqueous base, right? So it is more ideal for your exudative lesions, anything that has a little bit more pus or wet. Your fusidin cream would be more ideal there. It is also more ideal for the facial areas or the axillary areas. There's the ointment that is for your more dry or crusty lesions because it has more of an oily base. So it does have a longer contact time with the skin. Quickly mentioning the fusidin intertool, no, it is not available right now, but we're definitely working on a substitute. However, this is one of the mainstays in terms of burn therapy, ulcers, any large wounds. And how we've been advising our practitioners to substitute the fusidin intertool is by using non-adherent gauze along with the fusidin ointment, seeing that that is what was used to impregnate this gauze. So non-adherent gauze with the fusidin ointment should be able to replicate that effect for some of your dressings. So jumping into the steroid combinations, we have your fusidin H. So your fusidin H contains your fusidic acid along with your hydrocortisone, and this allows for double action against your dermatitis and your atopic eczemas. So you're getting both action from the fusidic acid covering for your Staph aureus and the hydrocortisone that is covering in terms of the dermatitis. And that combines to reduce bacterial overcolonization in the atopic dermatitis. Now, if you need a stronger combination, there is your Fusicort, and this contains your fusidic acid along with betametazone. So still very active against your dermatitis. It's just dependent on what you're seeing and if you do need the choice of a stronger, more potent anti-inflammatory agent. So again, highlighting some of the common topical conditions that your fusidin is useful in. Your impetigo especially is of note here because we have had situations in the past where there's been resistant impetigos and your fusidin ointment was one of the only options that could have treated it. Your erythema, folliculitis, paronychias, abscesses. In your burns also used in conjunction with your gauze, your non-stick gauze. Your fusidin line definitely provides all the choices that you need, whether strictly topical antibiotic or in combination with a steroid. Anything that you wanted to add?
Okay, ladies and gentlemen, you know, I always like to give you a little pearls or what you call some nuggets, right? The fusidin line of product, actually, it was discovered, can you imagine, in 1960, into the jungle in a mountain where there's a habitat of monkeys and animals, and they found this Coccium fusidium as a fungal on the ground, and they isolated it. And from then, it is like a revolutionary. Like for Staph aureus, the MIC level is 0.02. And when you look down on the subcutaneous fatty tissue, you have 4.4. It's hitting the bacteria like 1,000 times above MIC levels. However, as she mentioned, the cream, I know you go to adolescents. So some of you, when you see like acne patients, and you have to go to like the retinoids, Remember that that can be only used in the night times because of the ultraviolet sensitization. So you could cover your patient with the cream in the daytimes, penetrate these posterior air and the sebaceous glands, highly active against the Propionibacterium acne. And of course, the cream, as for some of you who have seen like the adolescents, when the apocrine gland becomes very active, secrete a lot of sebum enzymes and all these hormones, they get what you call a bad odor. It's called bromhidrosis. Fusidin cream work like magic in that area. Okay. All right. For the H and the Fusicort, sometimes you have youngsters who you want to retract penis. You could put on the H or the Fusicort for a day or two, and you can retract easily. And of course, Dr. Jackson, if she's here, she usually uses the Fusicort in umbilical granulomas as well. You could try that as well. So those are some little pearls. Thank you.
Well, we're not done just yet. Those were just some little pearls for the Fusidin line. So now jumping into our Advanton. So Advanton is our group 3 steroid, and it contains 0.1% methylprednisolone acetonate. So it is indicated in your moderate to severe eczema and psoriasis. And I really wanted to underscore that because Advanton tends to be boxed in as just the steroid that is used for kids. When you think of Advanton, you think of it, okay, it's just for your kids. The pediatricians love it, of course, and we appreciate that. However, it is definitely able to cover for your moderate to severe eczema. So please bear that in mind. Okay, so also continuing into your Advanton, it's bioactivated from your methylprednisolone acetonate into the more potent methylprednisolone propionate. So that allows for targeted action at the just where you need it in the skin, right? So you're getting rapid action, targeted potency, and this also lends to the safety profile of your Advanton because it is acting right at the site that you need it, and then it is rapidly deactivated by esterases if it gets into systemic absorption. So it is suitable for use from children 4 months and older. So you can start using it from 4 months upwards, and once daily dosage usage will suffice there. So just underscoring the key features of your Advanton, you're getting a favorable mode of action, high lipid solubility that contributes to that fast penetration across the skin. It's bioactivated right at the site of action, right where you need it, from your methylprednisolone acetonate to the more potent form. And it's convenient once daily application. Also, we have multiple formulations currently available on our market. We have the cream and we also have the milk. The milk is an emulsion, so it's an aqueous and oily mix, and that gives you a bit more contact time on the skin, and it's more suitable for the larger areas that's affected by the eczema. So both the trunk, the limbs, the milk would be more ideal there.
Okay, just to say that as pediatrician, you also have to be very careful. So the Advanton is a unique product for you. It has the potency as mometasone. However, if absorbed, it would neutralize. So the risk of like telangiectasis and atrophy is almost nil.
Okay, so jumping right into our Atrovine, this is your nasal decongestant, and it contains your xylometazoline hydrochloride, right? So the main thing that I want you to remember about your Atrovine is that you're getting that nasal decongestant effect within 2 minutes. 2 minutes, and you're getting that action. All right, so for children 2 to 11, it's 1 to 2 drops of a 0.05% solution, 2 times daily in each nostril. All right, so last but not least, there is your Shiderma, which is your 3-in-1 combination. It's antifungal, antibiotic, and a steroid, right? So there will be those situations that you have those rashes where you need coverage right across the board. Your Shiderma is available, and it's giving you antifungal, antibacterial, and anti-inflammatory action. So there might be mixed dermatitis or dermatomycosis, and you need coverage for both bacterial or fungal infections. Your Shiderma definitely is something that you can keep in mind. Thank you.
Okay, so this brings us to our third session, and I'd like to invite Dr. Wilson to tell us about neonatal acute kidney injury.
Good evening, everyone. Good evening, colleagues. Good evening, panelists, and general pleasantries. Thank you for attending. And I will be sharing with you my research entitled Neonatal Acute Kidney Injury, a Single Center Study in a Tertiary Care Facility in Jamaica. My research supervisors and principal authors were Dr. Sandrika Young-Peart and Dr. Natalie McNeil Beecher, and co-authors included Doctors Michelle and Richard Dawson and Dr. Carmen Roden Graham. Acute kidney injury in the neonatal population poses a diagnostic challenge because of their unique renal physiology. A comprehensive review of studies revealed a wide range of prevalence rates for neonatal AKI, spanning from 5.3 to as much as 70%. Common factors associated with neonatal AKI include prematurity, sepsis, dehydration, and exposure to nephrotoxic medications. Prior to 2008, the diagnosis of AKI in neonates was primarily based on arbitrary serum creatinine values, which were predominantly derived from adult studies. These values did not adequately account for the unique physiological characteristics of neonates. In 2012, Jeton et al. Developed the Modified Kidney Disease Improving Global Outcomes, or KDIGO for short, staging criteria, specifically tailored to neonatal AKI. These criteria have been rigorously validated in the AWAKEN study, which to date is the largest multi-center investigation to date, validating the use of this staging criteria for classifying and diagnosing neonatal AKI. Now, an extensive review of the literature shows a dearth of published regional and local data on neonatal AKI. Studies documenting neonatal AKI in territories with similar socioeconomic conditions often rely on arbitrary creatinine values, hindering international comparability. Our study aims to document the prevalence and epidemiology of neonatal AKI in Jamaica using the modified KDIGO criteria and classify available data using internationally acceptable guidelines. Our overall aim was to document the prevalence and epidemiology of AKI in neonates admitted to the special care nursery at the Bustamante Hospital for Children during the period September 1, 2023 to February 29, 2024. Our specific objectives were to calculate the prevalence of AKI in neonates admitted to the special care nursery at the Bustamante Hospital for the above period, to describe the epidemiology of neonates diagnosed with AKI, and to determine the factors associated with AKI severity in neonates admitted during the study period. We hypothesized that premature neonates with low birth weights who have a concurrent diagnosis of sepsis were more likely to have a more advanced stage of acute kidney injury. Now, this was a retrospective cross-sectional study that was conducted at the Bustamante Hospital for Children Special Care Nursery. The Bustamante Hospital for Children is the only specialist pediatric hospital in the English-speaking Caribbean that provides tertiary care to Jamaican residents and other Caribbean islands, offering multiple medical and surgical pediatric subspecialty services. A total of 357 neonates admitted between September 1 to 2023 and February 29, 2024 were selected and screened for eligibility. Data was collected from the medical records of 16 neonates who met the inclusion criteria using a data extraction sheet and analyzed using the Stata SE version 18. Categorical variables were analyzed by proportional differences using the Fisher's exact test, and a p-value of less than 0.05 was taken as statistically significant. And of course, our study adhered to the ethical standards approved by the UWI Mona Campus Research Ethics Committee and the Southeast Regional Health Authority, Jamaica. The data was exclusively used for the research objectives outlined for this research project. And of course, we adhered to strict ethical guidelines. Now, when looking at the results, so we first just want to look at the overall flow of our patients. So we initially started with a total of 357 neonates who were admitted during the study period. Now, a total of 32 records were excluded due to missing or incomplete medical records, inaccurate documentation of patient identification numbers, or there was no creatinine testing done during the admission period. And this left a total of 325 records that were eligible for screening. Of these, only 17 fit the inclusion criteria. However, only 16 neonates were included in the statistical analysis because there was one neonate who was diagnosed with a congenital anomaly of the kidney, ureter, and ureter tract, who was included in the study, but they never demonstrated abnormal serum creatinine values and so never tended to AKI and so could not have been analyzed for AKI severity. Now, when looking at the prevalence of neonatal AKI, the overall prevalence that was demonstrated in our study was 4.9% of the overall study population. And this pie chart demonstrates AKI stage. 44% of the study participants were diagnosed with AKI stage 1, while AKI stages 2 and 3 contributed 25% and 31% respectively. Now, it's important to note that this prevalence was lower than what was documented in other studies of similar socio-economic backgrounds. One such study in Thailand had the closest prevalence that was documented at 6.3%. And Thailand is classified as an upper middle income country, and Jamaica was classified as same in 2023 by the World Bank. And a study in Zimbabwe reported a much higher prevalence of 33% using similar diagnostic criteria. However, their population, they started measuring their abnormal serum creatinines from less than 24 hours of life. And so those would have been reflective of the maternal creatinine. And so those that may have been an overrepresentation of AKI in those patients. Now, when looking at AKI by gestational age, my apologies. Okay, my apologies. So in looking at AKI by gestational age, neonates with a gestational age of greater than or equal to 37 weeks represented 46%, 27%, and 27% of stage 1, 2, and 3 AKI cases respectively. Within the gestational age less than 37 weeks, there was 40%, 20%, and 40% with stage 1, 2, and 3 AKI respectively. In terms of AKI by birth weight was categorized as low birth weight if the participant weighed between 1,500 to 2,499 grams, very low birth weight if the weight was between 1,000 to 1,499 grams, and extremely low birth weight if they had a weight of less than 999 grams. 75% of the neonates with AKI had a birth weight above 2,500 grams with similar proportions across stages of AKI. 18% were low birth weight and 6% were very low birth weight. Now, among the normal and low birth weight neonates, stage 3 AKI was evenly distributed at 33%, and both normal birth weight and low birth weight neonates more commonly had stage 1 AKI, or very low birth weight neonates exclusively only had stage 2 AKI, and overall, AKI was more prevalent in our neonates of normal birth weight. In terms of the causes of AKI that we found in our study, dehydration was the most common cause of AKI at 26%. Now, these neonates were found to be dehydrated due to excessive vomiting in association with fever, inadequate intake of feeds, and subsequent development of jaundice. And however, none of these achieved any statistical significance when they were analyzed for AKI severity. Both congenital heart disease and sepsis accounted for 19% of cases. There was another 12% of cases that had multifactorial causes of AKI. And these causes would have included the effects of congenital heart disease, sepsis, and nephrotoxic microbial exposure. In our analysis of comorbidities associated with AKI severity, meningitis was the only statistically significant comorbidity with a p-value of 0.025. All neonates with meningitis had the most severe stage of AKI. Of our neonates with meningitis, which were 3 in total, 1 patient had a Klebsiella pneumoniae, which was isolated within their CSF, and the other 2 had Staphylococcus epidermis, which were isolated. Now, some limitations that we would have experienced in our study. So missing medical records may have contributed to the lower prevalence of AKI that was observed in our cohort. Our study additionally was conducted at a single center institution with a population primarily consisting of full-term neonates, which therefore limits the generalizability of the findings. Data on neonates with AKI in the very low birth rate and extremely low birth weight categories was limited, and this population was not well represented, well represented in our sample, and so true differences could not have been detected. These neonates tend to require urgent, immediate post-delivery care, and the Bustamante Hospital does not have a birthing facility, and so those babies would likely be admitted to a hospital that has a birthing facility, and so our numbers of those patients would have been less. And our small sample size. So in terms of the recommendations, so we would want to manage the individual risk factors for AKI, such as dehydration. So further strategies for preventing AKI onset could include managing individual risk factors, such as carefully monitoring the fluid intake and the urine output, as well as educating our public health team, as well as physicians and parents to recognize signs of dehydration. Implementation of protocols mandating close monitoring of the renal function and urine output, therefore detecting AKI earlier, and effective infection prevention control measures aimed at reducing the risk of sepsis and other infections, and of course, optimizing antenatal care, which would reduce the prevalence of premature births, which would overall reduce the incidence of AKI. Thank you so much for your time.
So we'd like to thank Dr. Wilson and welcome Dr. Broughton to tell us about renal manifestations in COVID.
Good afternoon, everyone. Okay, so good afternoon again. I am Dr. Broughton, and I'll be presenting the research that was done titled Renal Manifestations of COVID-19 in the Pediatric Patients Admitted to the Bustamante Hospital for Children, a single-center retrospective study. Co-investigators were Dr. McNeil Beecher and also Dr. Sandrika Young-Peart. So during the COVID-19 pandemic, extrapulmonary manifestations have become apparent in the pediatric population, especially renal manifestations, causing significant morbidity and mortality. The prevalence of same has been well documented, but outside of the Caribbean. Compared to the older population, children have significantly lower case fatality rates, experience milder symptoms, and recover more quickly than adults. However, presentation and clinical course can be very unpredictable, ranging from no symptoms of disease to being critically ill and requiring intensive care admission. According to the CDC, some comorbidities, namely diabetes, obesity, cardiac, lung, and neurological disorders, increase the risk of severe outcomes from COVID-19, and having more than one pre-existing comorbidity is actually associated with an increased risk of severe illness. It is known that SARS-CoV-2 primarily affects the lungs, regardless of the presence or absence of any underlying illness. But it may also affect other organ systems, namely the kidneys, the myocardium, the hepatobiliary system, and the central nervous system. The incidence of kidney involvement in COVID-19 globally was found to be around between 10 to 15%, higher than previous viral outbreaks such as SARS. The most common renal manifestations in children admitted to the ICU was acute kidney injury. However, other manifestations have also been reported, namely hematuria, proteinuria, and rhabdomyolysis. Risk factors for developing acute kidney injury were found to be quite multifactorial. As mentioned before, you have the presence of comorbidities, but also genetic factors play a role, and also other associated presenting symptoms. For example, GI losses, dehydration, or as a direct result of the treatment the patient may have received during the admission, fluid overload, high ventilatory requirements, and the use of nephrotoxic drugs. So in terms of the rationale, so while the course of COVID-19 is generally milder in the pediatric population, there has been notable occurrence of extrapulmonary manifestations. The risk of renal involvement, including kidney injury, but not limited to same, is significant and correlates with heightened morbidity, as observed in developed countries. Studies globally have varied outcomes, ranging from reported no renal manifestations as far as up to 50% developing acute kidney injury, with it seen predominantly in seriously ill patients. And just to note, less than 1% of the global, in terms of the researches that I've seen, receive dialysis. Data specific to the pediatric extrapulmonary and renal manifestations of COVID-19 in Jamaica and the Caribbean remains limited. Identifying these manifestations in this context is crucial for improving management and developing preventative protocols as COVID-19 becomes an endemic. The aim of this study was to determine if patients admitted to the Bustamante Hospital with confirmed COVID-19 infection had renal manifestations, and so two objectives were coined. Firstly, to describe the epidemiology and clinical features of patients admitted with COVID-19 infection and renal involvement at the Bustamante Hospital spanning from April 1st, 2020 to April 1st, 2023. Secondly, to determine the prevalence of acute kidney injury in patients admitted with COVID-19 infection to the Bustamante Hospital in the above study period. So this was a retrospective descriptive analysis utilizing medical records of children admitted to the Bustamante during the outlined study period, which had spanned the first 3 years of the pandemic. Confirmation of COVID-19 infection was a documented positive test for SARS-CoV-2 on real-time transcription polymerase chain reaction assays or having positive COVID-19 antibodies. To note, ethical approval was granted from the Mona Campus Research Ethics Committee and also the Southeast Regional Health Authority. All admitted patients with a positive real-time PCR positivity for COVID-19 who were admitted to the Bustamante Hospital are logged by the Infection Control Department. And this, along with the patient administration system, was used to identify those with COVID-19 diagnosis. Renal involvement was defined as the presence of acute kidney injury, and to note, the staging criteria used was KDIGO, kidney disease improving global outcome. Other renal involvement was not limited to acute kidney injury. We took into consideration the presence of hematuria, proteinuria, leukocyturia, urinary nitrites, and also oliguria. Our inclusion criteria, it was children less than 12 years old. They had to have had confirmed COVID-19 infection, or they had fulfilled the CDC criteria for Miss C. They had required admission to the hospital and had a documented serum creatinine measurements. Those who were excluded, of course, the opposite, those who were greater than 12, those who were suspected but actually not confirmed to have COVID-19 or who didn't require admission, or those who just didn't have any documented serum creatinine during their admission course. So in terms of the results, this is a table firstly showing the characteristics of all pediatric COVID-19 patients admitted to Busta during the study period. To note, 151 out of 250 records were used in this study and they had satisfied the inclusion criteria. To note, 74% were actually ages 0 to 3 years, and the majority of the population actually originated from the Kingston and St. Andrew region. To note, 15 of the patients, out of the total 151, had diagnosis of multi-system inflammatory syndrome in children, coined MIS-C. Now, this table, the most common clinical features on presentation by organ system was noted to be respiratory in origin, secondary, we have gastrointestinal presentations, and thirdly, dermatological presentations. And just to state that 40% of the population had a coexisting comorbidity. This just demonstrates the prevalence of renal manifestations based on our study, and that was found to be 15%. This table now shows the characteristics of COVID-19 patients admitted to Bustamante during the study period, and this focused more on renal manifestation status. 23 out of the 151 patients that we had looked at had renal involvement. To note, there was an even split between male and female distribution, and the median age was found to be 3 years old. And interestingly, those less than 1 year were most likely not to have any renal manifestations. Among those with renal manifestations, 48% had MIS-C. So this bar graph is showing the prevalence of comorbidities among patients with and without renal manifestations. Among the participants with renal manifestations, 74% had comorbidities, while 26% did not. On the contrary, for our participants without renal manifestations, 34% had comorbidities, while 66% were without. Among patients with MIS-C, 73% were actually noted to have renal manifestations in comparison to 8.8% in those with acute COVID infection, and this was deemed statistically significant. This bar graph is just showing the presence, 3 renal manifestations that were noted to be more common in this study, namely AKI, urinary nitrites, and proteinuria. These are 2 pie charts showing the prevalence of hematuria and oliguria in the study. The prevalence of hematuria, as we can see, was found to be 4%, so of note, 15% did not have hematuria. Interestingly, the remaining 81% of our participants actually had undocumented urinalysis results to ascertain the presence or absence of these parameters. We had spoken about the prevalence of renal manifestations being 15%. However, when taking a closer look in terms of acute kidney injury, the prevalence was found to be 7%. In terms of categorizing those who had acute kidney injury by staging, it was found that stage 2 was actually the most prevalent, accounting for 55% of cases, followed by stage 3, which had 27%, and stage 1 at 18%. This table speaks to the clinical outcome of COVID-19 patients by acute kidney injury status. Fisher's exact test revealed that pediatric ICU admission was significantly associated with acute kidney injury. Among those admitted to the ICU, pediatric ICU at that, 83% had acute kidney injury, a statistically significant finding. So having a diagnosis of acute kidney injury is more likely to warrant a PICU admission. And to note, in this study, none of our patients had required renal replacement therapy. So in conclusion, COVID-19 infection in the pediatric population is associated with renal manifestations such as AKI. And to reiterate, in our study, 15% were found to have renal manifestations, while 7% was noted to have AKI. This, prior to this study, was known, the global incidence was actually known, but now we have local evidence of same and the parameters to monitor in terms of to identify, lessen, or prevent morbidity and mortality going forward. The clinical sequelae may range from being asymptomatic to being critically ill, requiring intensive care admission. Patients known to have comorbidities are more likely, again, as we said before, to be diagnosed with acute kidney injury and multi-inflammatory syndrome in children. And screening for renal manifestations is recommended in patients presenting with COVID-19 infection, improving management, and ultimately improving management, allowing for early intervention. And just to state some recommendations, renal function surveillance, along with preventative protocols as common practice to assist in the early identification and management in pediatric patients. And lastly, just to reiterate the importance of nephroprotective measures such as hydration and avoidance of nephrotoxic medication. Thank you.
Yes, we thank Dr. Broughton. We will welcome Dr. Stephan Brown to tell us about chronic kidney.
Good afternoon. No, good afternoon. All right. Good afternoon. I'm Dr. Stefan Brown, and I'll be presenting on chronic kidney disease epidemiology, as well as outcomes in Jamaican children presenting to the Bustamante Hospital for Children. My principal advisors were Dr. Sandrika Young-Perrett, as well as Dr. Natalie McNeil-Beecher. I have no conflicts of interest, and there are no financial interests with this study. So chronic kidney disease. This is characterized by a structural as well as a functional abnormality that is present for at least 3 months. This can be a gross pathological abnormality, a laboratory-based derangement, or an abnormal radiological finding. Conversely, we understand that a reduced GFR as well as persistent proteinuria, or both these manifestations, can also be constituted as chronic kidney disease. Chronic kidney disease remains a conundrum of public health, with more than 500 million people living with this condition for the adult population in both low and middle income countries. However, a vast paucity of data still exists within our pediatric population. For my study, I wanted to describe the spectrum of chronic kidney disease in Jamaican children, presenting to the Bustamante Hospital for Children in both inpatient as well as outpatient settings between January 1, 2010 and December 31st, 2020. I also wanted to document the incidence of chronic kidney disease in Jamaican children presenting to Bustamante less than 12 years of age during this study period. I also wish to document the comorbidities associated with this condition, as well as the clinical outcomes 2 years post-diagnosis. Now, why CKD? Patients with early stages of CKD are often asymptomatic, and as a result, they go underreported. Unlike the adult population, epidemiological data on pediatric CKD is infrequently documented. And with limited studies in the English-speaking Caribbean, I thought it was important, warranted, and crucial to both update and re-examine the epidemiological data surrounding pediatric CKD. This was a retrospective study. I utilized docket review at the Bustamante Hospital for Children with a patient administration system using specific ICD-10 codes. The review encompassed all patients with suspected or confirmed cases of kidney disease that would have presented to Bustamante between January 1, 2010 and December 31, 2020. Data was collected, of course, post ethical approval, entered and securely analyzed on the SPSS software. These patients must have been less than 12 years old at the time of presentation to Bustamante. Patients must have been diagnosed with CKD during the same study period, that is with a reduced estimated glomerular filtration rate for at least 3 months, or those born with abnormal renal abnormalities, Inpatients that were referred to the nephrology service must have been patients who were diagnosed with CKD, as well as outpatients with the same diagnosis. Patients whose medical records were not available at the time of review were excluded, as well as any child that was greater than 12 years old at the time of initial presentation. Now, for the purpose of my study, I needed a definition for adverse clinical outcomes. I came up with a reduction in the estimated GFR over a 3-month period, persistent proteinuria, persistent hypertension, and increased number of admissions for that patient, as well as death. As it relates to the results of my study, I was able to identify 55 cases of pediatric CKD that had satisfied the inclusion criteria between January 10 and December 2020. With 117,127 cases that were noted within that study period, I noted an incidence of 46.96 per 100,000 cases. This is comparable to other figures or other studies that were done locally by our very own Dr. Marilyn Miller, where we see an increase in the incidence of pediatric CKD. Of the 14 parishes, the majority of our cases originated from St. Catherine, with 14 cases total. Bustamante was also highlighted as the main source of referrals towards the nephrology center for patients with suspected or confirmed cases of CKD. In line with international studies, our patients were also noted to have a male preponderance, with 43 males noted, while 12 participants noted to be females. On average, the study population was noted to have an age of 5 years old. This had ranged from a range of 2 weeks old to as max of 10 years old. Of the cases seen on referral, an abnormal radiological investigation was the most common cause. And when those patients were seen in clinic, fever as well as vomiting was the most common presenting complaint or clinical feature that was seen at initial presentation or initial assessment prior to their diagnosis. Now, I wanted to go through, for this study, certain parameters that we used to describe chronic kidney disease. Estimated GFR at diagnosis was on average 74, ranging between 4.67 to 171, while at follow-up, this had improved to 128.87. Anemia, as well as elevated creatinine, was noted at both diagnosis as well as follow-up for our patients. Interestingly, proteinuria cases had gone on the decline. However, the quality of proteinuria we had noted from a urinary spotted protein to creatinine ratio had increased. Calcium and phosphate levels had remained normal amongst my study population on average, even though these numbers varied widely. As it relates to the cause of CKD, posterior urethral valves as well as recurrent urinary tract infections form the most common causes of pediatric CKD. Treatment of recurrent UTIs, failure to thrive, and decompensated kidney function form the basis of reason for admission back to hospital for treatment. The longest stay in hospital was between 1 week and 3 weeks and 6 days, with 28 cases. As we can see from the table, other causes of pediatric CKD followed reflux nephropathy as well as cystic disease, Common radiological findings that were noted amongst my study population as it relates to abdominal ultrasound include hyperechoic kidneys as well as renal parenchymal disease, while on MCUG, we noted features of posterior urethral valves as well as posterior urethral dilatation. Patients who had renal scans done commonly were noted to highlight reduced split function as well as impaired absorption. Going back to the objectives of my study, I wanted to detail the complications or the comorbidities associated with pediatric CKD. The top one for us was anemia, with 26 cases noted at diagnosis and 19 cases at the 2-year follow-up. As we can see, the other list of complications or comorbidities that are seen amongst our study population. Interestingly, we did note that of the 55 cases, 21 cases were lost or defaulted to follow-up. In conclusion, I thought that we found critical insights into pediatric CKD within a Jamaican context, highlighting the demographic, clinical, and therapeutic challenges associated with this disease. I highlighted an increased incidence in pediatric CKD compared to the previous studies done in our very own local setting. This emphasized an importance of CKD in our population and the associated morbidity as well as the mortality. And I also noted that the future research should focus on genetic as well as environmental influences on CKD and explore the efficacy of management protocols to address the unique challenges associated with this population. Limitations. This was a single-centered respective study that, along with the relatively small sample size, will limit its generalizability. The reduced availability of files for analysis is also a limitation, as well as much of our files are written, and so therefore information may be hard to gather if it's not easily understood or legible. Recommendations that we gathered from our studies that educational opportunities like this one should encourage additional training to create professionals that will be able to assist in identifying at-risk patients and patients with chronic kidney disease. We thought routine imaging as well as early urologic assessment as screening in our pediatric patients would be imperative. Advanced resources to ensure adequate investigations as well as regular follow-up to identify and monitor these cases and their potential complications. And I wanted to also implore policymakers as well as government leaders to revisit funding as well as resource allocation to public health facilities that would aid in treating as well as managing our cases or rising cases of pediatric CKD. I want to acknowledge Dr. Sandrika Young-Peart and Dr. Natalie McNeil-Beecher for their assistance with this project. These are my references, and thank you.
I'd like to invite the presenters for this section to come for a question and answer, and I'd like to open the floor to questions. Where's the mic? Oh.
Who's coming with it? You want to go first?
I'll go first. Here you go.
All right, so overall, the presentations were well structured, but I found all three presentations had kind of the same weakness. I didn't see any reference, no, a reference to your literature review. So I didn't see that on the slides really. But just to get to the questions, if you could all help me with this. So Dr. Brown, you mentioned at the beginning of your study that there were no real data related to prevalence in children. And then on your rational slide, you then indicated that there's infrequent documented evidence. But in your results, you were actually able to compare your results with two studies. So I'm trying to figure out, where is it? Is there no data? Was your study not informed by anything in the literature? How did you put your sample numbers for this?
Thank you. Thank you for that question. My study was informed by international studies. There are a few international studies, both internationally as well as regionally. Fortunately, we're able to have Dr. Melanie Miller, who has done 2 studies previously on this topic. However, those were, in my opinion, dated, and I wanted to update them and re-examine the epidemiological data surrounding pediatric CKD.
Yeah, that's wonderful.
Go ahead.
Yeah, that's wonderful. And I mean, that's what we would have expected to hear. I didn't really see any of that. So thanks for that.
Dr. Brown, you know my regular question, but before I get to it, I'll ask you said that chronic kidney disease was, you're describing the epidemiology, you said it was more predominant among males. You didn't say why. And please don't tell me international studies say. I want you to tell me about pathophysiology and what you think from your knowledge as a bright young pediatrician.
Okay, so our male population, unfortunately, which I'm a part of, we are at risk of pediatric CKD because of our anatomy. With our likelihood of presenting with posterior urethral valve, which predisposes us to recurrent urinary tract infections, it can cause renal injury or renal scarring that can later present as chronic kidney disease.
Well done.
And the majority of our patients are.
So what is novel about your study so I could accept it in my journal?
I think you should accept my study in your journal to further the talk on chronic kidney disease within our pediatric population, especially since—
My journal, international journal, I don't care what happened, I bust them, auntie. What does the readership wants to hear that is novel in your study? The wide readership across the world.
The rate of pediatric CKD is increasing, and it's important for our clinicians to be able to recognize as well as treat it to prevent morbidity as well as mortality.
Thank you.
Thank you.
All right. So let me go to Dr. Wilson. So similar issue I had there in terms of the literature review to support the justification for your study. You did present some evidence of incidence or prevalence, whichever one it was that you used. I think it was prevalence. It was from 5.3 to 70. I thought I was curious, and I wondered if you wanted to maybe have a little more discussion on why is it so wide? When the studies that you look at, did you maybe look at the research design to see if they were all useful for your literature review?
Okay, thank you so much. And very interesting question. So the study, the prevalences that I would have obtained from the literature review would have been so varied because there would have been multiple factors that would have been considered for all of those studies. So the first thing is that a lot of those studies were taken from multiple different areas. So what we did was to look at first world countries versus poorer demographic countries versus more Caucasian-centric countries versus more Afrocentric countries. So the population would have been varied. Our study was not necessarily looking at those, so that's why that wasn't necessarily highlighted in our study. In terms of the other reasons why it would have been so varied was as we recognize from the various diagnostic criteria that would have been utilized throughout all of those studies that not everybody was utilizing what is now accepted worldwide, which is the modified neonatal KDIGO. Some persons would have been using the AKI criteria, some persons would have been using the RIFA criteria, some persons would have been using very arbitrary serum values. And so they may have been reporting the prevalence that they would have been getting. But when you look at international guidelines, those may not have been representative and true representation of what their actual prevalence was.
All right, thanks. That's a very good answer. So I look forward to actually looking at the document itself and seeing some of those variations discussed. The other part that I don't think I really saw what stats you used, and I'm a little concerned about the table that you had where you were comparing them across the stages because it was 16. So in some of them it was 0, 1, and you were coming up with some nice p-values. So I was a little concerned about what stats you were actually using. So I don't know if you remember the exact table, but perhaps you remember what statistics you had used to get those nice p-values when, for example, there was one where it was all the cases 100%, which could maybe be 2 or 3.
Right.
Was in just one stage, and the rest of the stages you didn't have any numbers.
Right. So my apologies for not mentioning, but the Fisher's exact test was used to obtain those p-values. And I do agree in terms of the small sample size, and that would have been a limitation to the study. And perhaps with a larger sample size, we would have been able to achieve even more significant
Maxine, no more questions.
p-values.
I am limiting Professor's time because it is late in the night. So I'll ask my questions. If you're when you're writing your paper, you stated that when you look at comorbidities, meningitis was a comorbidity with your neonatal kidney disease. How would you comment on that in a paper? And were you surprised? And
so I actually was quite surprised. Oh, I'm sorry, did I cut you off?
No, go ahead, go ahead.
Okay. So I'm actually quite surprised that we yielded that because no study that we reviewed actually showed a significant association between meningitis and severity in AKI. And so
again, I don't want you to tell me about other studies that Starsky and Hutch did. I want you to tell me, from your knowledge of pediatrics and medicine and biology, how would you comment? Or would you comment? Or you say this is just there's no causation, for example. And it's very late, so answer quickly.
Okay, so patients with meningitis may overall be more clinically unwell and may have a longer, more turbulent admission course. And so they may overall have more severe complications of their illness, of which severe AKI is one.
Thank you. You also said that one of your recommendations was management of dehydration, but wouldn't that be standard clinical care?
So in my experience, it actually is not. So there are many persons in the population who actually do not know how to manage dehydration. Let us say, for example, they think that if a patient, a baby, say for example, is dehydrated, the correct thing to do is to give sugar water or to give bush tea or mint tea. And so those inappropriate measures or primary care measures of managing dehydration could prolong and make the illness more severe. And so if at home there was some basic initiation and understanding of how to adequately treat this, then maybe the severity of the patient when they present to us may not be at a stage 3, but they may present at a stage 1, for example.
And very briefly, why should your paper be published? Why should the paper be published?
Okay, so I think our paper should be published because it is the first study not only in Jamaica, but in the region that looks at neonatal acute kidney injury and applies worldwide internationally acceptable diagnostic criteria to classifying acute kidney injury. It also does add to the overall wealth of knowledge that we have about acute kidney injury. And this study, though it had a small sample size, could serve as a pilot for future work in terms of looking deeper at this issue. Thank you.
Dr. Barton? Okay. All right, Dr. Barton. I had a question related to the association COVID-19 and renal manifestation. I mean, you had a good number, 151 sample, But I didn't see the listing of the comorbidities and how you ruled out the comorbidities, because couldn't they have had comorbidities that were associated with the acute kidney injury?
Okay, so in terms of identifying those with comorbidities and collecting our data, that was one of the questions that we had to fulfill in terms of answering, and that had spanned different organ system. Respiratory had spanned from like asthma, hematological spans, sickle cell disease, and based on the different organ system, we had picked up the different comorbidities. And interestingly, out of the 151 patients, actually no patients had any renal complications in terms of comorbidities.
In the interest of time, I'll just ask you, what is novel about your paper? What did you find so novel that you think that it should go into a journal? And I'll yield after that.
Okay, so we are coming from an era where we thought we were outside of in terms of communicable diseases being worrying about that kind of concern. But given the recent emergence of communicable diseases, every month we have a new virus, something that we're not familiar with, and it's not just a respiratory virus like the flu that, you know, people are not really concerned about, but we're finding that there are real complications and real concerns and real cases that affect morbidity and mortality. It's a good thing to look at and identify, and this may not be the last pandemic, they might be there in the future, so it's a good guiding light in terms of our way forward.
So I'd like to thank presenters. And while we move straight into the final session, I'll just use moderator privilege to say that what we should really be saying is that there are no known published studies. Okay, so let me invite Dr. Wisdom.
Okay. Hello. Hi. Hi, good night. So journey with me as we explore food behaviors and sensory patterns in children with autism spectrum disorder at the University Hospital of the West Indies. Our team comprised of Dr. Garbut, Dr. Olibwe, and myself, Dr. Daniel Wisdom. The DSM-5 defines autism spectrum disorder as impairments in social communication and interaction, plus the presence of restricted, repetitive, or stereotypical.
So we'll just start over her time.
Right. So the DSM-5 defines autism spectrum disorder as the impairment in social communication and interaction, plus the presence of restricted, repetitive, or stereotypical behaviors. And this deficit is not better explained by any other general medical condition. The prevalence globally is 1 in 160 children with a male predominance. And in USA, the CDC reports a 1 in 36 prevalence. Unfortunately, there has been limited data on prevalence in the Caribbean region, although we've made significant strides in early diagnosis and intervention. Now, there's a significant prevalence of about 46.8% of GI issues among ASD individuals, according to studies across the UK, Canada, and USA. And children with ASD often experience constipation, abdominal pain, and diarrhea. Food behaviors and preferences in children of ASD that are shaped by their sensory sensitivities, restricted diets, as well as unique mealtime behaviors. And currently, there is no established standardized dietary regime in the management of ASD. Mealtime behaviors refers to the attitudes, actions, and habits displayed by individuals during eating, and it's encompassed by food intake, social interaction, and their adherence to meals. There are 4 common mealtime behaviors found among the ASD population, and they're listed here. Studies across the region consistently reported problematic mealtime behaviors in children with ASD as high as 93%, with highest rates related to food selectivity for strong preferences for textures and flavors. And these problematic behaviors often result in limited dietary variety, nutritional deficiencies, and poses an increased risk of obesity. Mealtime behaviors can be assessed through several tools. However, currently there only stands one standardized tool exclusive for the ASD population, the Brief Autism Mealtime Behavior Inventory, or BAMBI. And it benefits by providing early identification for feeding challenges, allows one to track progress over time, and guides with personalized nutritional intervention. Sensory processing refers to how one's nervous system receives messages from our senses and turns these into motor and behavioral responses. There are distinct sensory patterns such as sensitivity, seeking, avoidance, and registration, and these can be found in any individual. Winnie et al. Showed that children with ASD may demonstrate either hypo or hyper responsive to their sensory stimulus. And the short sensory profile tool is a tool that can be used to identify as well as classify these distinct sensory processing patterns among the population, where sensitivity, particularly to textures, color, taste, or smell, can strongly be associated with food selectivity and feeding difficulties in this population. Now, the rationale of our study is because there's limited data on feeding behaviors and sensory patterns in the ASD population across the Caribbean region. And so we aim to address this gap to provide aids in intervention. Our aims and objectives are to describe the food preferences, the common food behaviors, describe the sensory processing patterns in children with ASD in our clinic, and to explore if there are any associations between sex, BMI, their sensory patterns, and those who were identified as problematic mealtime behaviors. Our study was a descriptive cross-sectional study over 4 months, and our pre-hoc analysis sample size was 100 participants, based on an estimation that 40% of the ASD population will exhibit problematic mealtime behaviors according to studies across the world. Now, 88 of our participants were found due to time constraints, unfortunately, and 3 of our participants from that 88 were eliminated due to missing data from the BAMBI scores. We did an electronic formatted parent-reported questionnaire that was administered, which also included the BAMBI and the SSP2, as well as reviewed the docket to get anthropometric data to calculate the BMI for each participant. A descriptive analysis of the patient characteristics, as well as an analysis of the association between the mealtime behaviors and their demographic and sensory patterns, was conducted using the SSP2 version 29. Now, the most common parent-reported comorbidity was found to be global developmental delay at 16.5%, followed by ADHD at 15.3%. And our most common GI symptom associated was constipation, where significant scores amounted to about 28.2%. A third of our study had classified as overweight and obese. 55% of our children were identified as problematic feeders, where they had a significant score of either greater or equal to 34 on their BAMBI. The most common mealtime behavior was food selectivity, where 65 to 73.5% of children either dislike certain foods or prefer the same foods at each meal. This was followed by mealtime rigidity, food refusal, and least disruptive mealtime behaviors. Now, the sensory processing patterns are here described. Seeking, which is how the child obtains sensory input. Avoiding, how they're bothered by sensory input. Sensitivity, how the child will detect their sensory input. And registration, how they miss sensory input. Over half of our study population displayed heightened responses to their sensory stimulus, with the most common related to sensitivity at 56.5% frequency. Unfortunately, there was no significant association found between sex, BMI, and sensory patterns with those who had problematic feeding behaviors. Through a covariance analysis, the strongest association was found between the seeking pattern sensitivity and those who had high Bambi scores. So this means that a higher problematic feeding score was correlated with strong senses of sensitivity. Now into our discussion. There was a male to female predominance that aligned with global prevalence at 4 to 1, where 80% of our population was male. Parent-reported associated comorbidities such as GDD and ADHD were mostly reported, but these were less than the international studied rates found, where GDD was high as 34%. Constipation had affected 28.2% of our participants, and this had fell within the international reported range. Significantly, our cohort showed a 3.6-fold increase in comparison to the global childhood obesity rate of 8%, but our prevalence was parallel to other studies across Europe and UK and US. Food selectivity, as said, was the highest found mealtime behavior, where there was significant preferences to crunchy foods, which was similar to global findings at 54 to 94.3%. And this shows that there are significant texture-related challenges among the ASD population. And as said before, hyperresponses were the most common relation to processing stimulus from the sensory. Hyperresponses were common among the ASD group, and this had closely mirrored international cohorts. And this shows that there's a global relevance of sensory challenges in the ASD population. Now, our limitations. The study's findings may not have been representative of all children with ASD, as you know, the Jamaican demographic, socioeconomic, or to really represent the region. But the Child and Family Clinic is the only clinic that responds to behavioral challenges in Jamaica. With relates to our small sample size, our study had identified a prevalence of 57% of problematic feeders, which was greater than our initial pre-hoc analysis probability of 40. And so by post-hoc analysis, the statistical significant sample size was actually 80 participants, and we got 85. So we were significant. There was potential bias in parent reports from the Bambi and the SSP2, and this would benefit from the recall of the parents, and that might pose some bias. And there was non-validation of the assessment tools, the Bambi and the SSP2. However, we did do a pre-test of our questionnaire to ensure that there was cultural appropriateness before we had conducted our study. And so in conclusion, we found that the UE-ASD population exhibited feeding behaviors consistent with global trends, where food selectivity was the most common, and sensitivity emerged as the predominant pattern influencing these behaviors. The management of ASD should then not be limited to therapies such as applied behavioral therapy, speech and language pathologists, or educational placement, but we must take a multidisciplinary approach to integrate sensory strategies, behavioral, and nutritional counseling, collaborating not only with our parents, the dietitians, the occupational and behavioral therapists. And so we recommend that routine standardized screening for mealtime behaviors be utilized by using the tools such as the Bambi. It offers identification of these feeding difficulties early and will allow for timely intervention. Integrating these findings can allow us to target management as well as to track effectiveness. And addressing sensory sensitivities should help in aiding to ensure that these problems can be identified in any rigid eating behaviors. Applying a multidisciplinary approach is always key. And then final and foremost, for holistic care, individualizing target nutrition for this population. Thank you.
Okay, so we thank Dr. Wisdom and we welcome Dr. Kojo.
Good evening, everyone. It's my privilege to present my research project, which is entitled Behavioral Sleep-Related Disturbances in Children with Autism Spectrum Disorder. Principal investigators were Dr. Garbot and Olugboyi, and myself was the co-investigator. Now, as mentioned, autism spectrum disorder is a neurodevelopmental condition that is defined by the DSM-5 as having persistent deficits in social communication and interaction, restricted repetitive patterns of behaviors that present in the early developmental period and is not better explained by other conditions such as global developmental delay or intellectual disability. Sorry. Something. Sorry about that. So the Autism and Developmental Disabilities Monitoring Network looked at the prevalence of ASD in 2000 compared to 2020, and they found that in 2000, as was mentioned, it was 1 in 150 children versus in 2020, where it was found to be 1 in 36 children. And this increase in the prevalence could have been due to the fact that over the decades, there have been more awareness of ASD, which has led to earlier screening and earlier diagnosis. Now, sleep is very important for a child's healthy development, and there are various theories on why we need sleep, which include inactivity theory, the restoration theory, energy conservation theory, and the brain plasticity theory. Now, the brain plasticity theory proposes that sleep is essential for the neural reorganization and structure of the brain development, and this proposes why infants and young children require higher amounts of sleep compared with an older child, as well as why during infancy and early childhood, there's rapid brain development and growth. Now, sleep, there are many adverse outcomes that occur in a child who does not get an appropriate amount of sleep. And these can include physical adverse outcomes, such as a higher risk of developing obesity and diabetes, as well as behavioral challenges. So these children are at higher risk of developing aggressive behavior, hyperactivity, as well as deficits in your cognition, memory, and learning. So it's important that sleep issues are addressed timely and adequately. Now, sleep disorders are present in both the typical and atypically developing pediatric populations. Studies have shown that they're more prevalent in children with ASD at a rate of 50 to 80% compared to 11 to 37% in the typically developing population. Studies have also found that the type of sleep disturbances are similar in both the typically and the atypically developing pediatric population, but overall, behavioral sleep issues are the most common, such as bedtime resistance and insomnias. And we see some studies here looking outside of the Caribbean, such as China and USA, where they also have found significant rates of behavioral sleep disturbances as well. Now, parental knowledge of sleep is very important as well, because children are dependent on the parental sleep knowledge to ensure that their sleep needs are being met and their sleep difficulties are being addressed. And research has shown that parental understanding of sleep is linked to improved sleep duration as well as better quality of sleep in children. So the aims of this study were to determine the parental knowledge and beliefs regarding sleep and to describe the behavioral sleep-related disturbances in children with ASD. And some of our objectives were to describe sleep patterns and to screen for behavioral sleep problems in children with ASD, as well as to determine the parental knowledge of sleep. This was a cross-sectional study and was conducted at the University Hospital of the West Indies, as well as the Jamaica Autism Support Association. Our inclusion criteria were parents and caregivers of children diagnosed with ASD between the ages of 4 to 10 years old, and they must have been a participant in the sleep process. And our data collection tool was in the form of a self-administered parent questionnaire, which included a children's sleep habits questionnaire, as well as the parental sleep knowledge questionnaire. And these tools have been validated externally, but permission was granted for same by the creator to use in our study. Our sample size, which would have powered our study at 80%, was 75 participants, and we had 83 participants that met the study inclusion criteria, Data analysis was performed using the SPSS version 28. In terms of our results, significant, we found that boys were found to be 79% and girls were 21% of the study. And so boys were found to be 3.8 times more than girls in our study. In terms of our sleep pattern, significantly, we found that 45 or less than 50% of our children were found to have a consistent bedtime. for most days of the week, and earlier and consistent bedtimes have been shown to be linked to better sleep outcomes in children. Our common sleep disturbances that we found were delayed sleep onset, bedtime resistance, night waking, and daytime sleepiness. And these were comparative to the studies that we found earlier in USA, China, as well as India. Looking at parental sleep knowledge. So the sleep knowledge questionnaire consisted of 10 true and false questions, with adequate sleep knowledge being demonstrated by a parent answering at least 5 of the 10 questions correctly. And we found that 67% of our parents were able to achieve this, this quota. However, we found that our parents had deficits in various questions that they answered. So they performed better in the questions related to pre-bedtime behaviors, but they had performed poorly when it comes to looking at the duration of sleep that a child required and consistent bedtimes during the weekdays and the weekends. The Children's Sleep Habits Questionnaire is a 33-question questionnaire that looks at various domains of sleep, for example, bedtime behaviors, daytime sleepiness, and a cutoff score of 4 to 1 and less indicates that this is a good sleep score and the child is less likely to have a sleep disorder, where a score of 4 to 1 and 4 to 2 and more indicated that a child was more likely to have a sleep disorder and required further investigation. This tool has been used in over 300 research projects, and it is a screening tool that is very popular in the pediatric population. In our study, we found that 3/4 of our children had scored 4 to 2 and more on the Children's Sleep Habits Questionnaire, which indicated that they were more likely to have a sleep disorder and required further investigation. Looking at our educational status of our parents, we found there wasn't much variation in terms of the tertiary education in our parents for the children who had high sleep scores versus those who did not. But we found that for the parental knowledge, it was greater in the group of children that had lower sleep scores compared to the children who had higher sleep scores. For our parental sleep beliefs, we found that for the children who had lower sleep scores, the parents were more confident in their belief that their child was getting enough sleep and taught the child that healthy sleep behaviors, compared with the group that had greater sleep scores. Those parents were displayed more doubt in the belief that their child was getting enough sleep and was more desirous of speaking with their child's physician about their sleep habits. Looking at our comorbidities, we found that 50% of the children had at least one comorbidity. And although our parental knowledge of sleep overall was found to be adequate, we found that there were significant gaps that needed to be addressed. In terms of the Children's Sleep Habits Questionnaire, we found that 58% of the children were on medication within the preceding 2 weeks to assist with sleep, which further underscores the complexities of managing sleep challenges with children with ASD, along with those who also have more comorbidities. So our study, in terms of our limitation, the study was limited to children aged 4 to 10 years old because this is the age group in which the tool was validated. In addition, there was no comparative data from typically developing children in the general population. In conclusion, this study is the first of its kind in Jamaica and the Caribbean at large, and the findings revealed a significant amount of our children with ASD who required further screening for sleep disturbances, and it also highlighted the gaps in parental knowledge that needs to be addressed. Our recommendations that came out from this study included routine screening for sleep disturbances, as well as integrating sleep education and sleep specialists within the child and family clinic, as well as targeted education for the parents themselves, since our children do rely on our parental knowledge to ensure that their sleep needs are being met. And a comparative study of sleep disturbances in typically developing children will also be important. Thank you.
Thank you, Dr. Kojo. And we welcome Dr. Olivia Lockhart, who is online from the Bahamas. Dr. Lockhart, you're going to share your screen.
All right, can everybody hear me?
Okay, we can hear you. We are seeing your screen and it's now in presenter view. Can you
One second.
put it in slideshow?
Okay, you can see it now? I can't see it.
No, we are seeing you. We are not seeing your screen. We were seeing it before. You just needed to put it in slideshow. Do you have an IT person nearby who can assist you? Hmm? She's talking to somebody. No, she's talking to somebody. I don't think she's talking to us. I think she's talking to us. Hello? You're muted? You're muted and we are not seeing your screen.
One second, I'm trying to fix it right now.
We have the presentation. Do you want us to share? Do you want us to put up the presentation?
No, one second.
Okay. Okay, so just put it into slideshow. Yes. Oh,
Okay, you can see now?
yeah, we'll see. Just go ahead.
Okay. All right, my apologies for the little hiccup. So I'm Dr. Olivia Chase. My topic is evaluating the knowledge of parents and caretakers in New Providence, the Bahamas, on the risk and preventative measures for sudden infant death syndrome. Below are my contributors that aided in helping my study. So sudden infant death syndrome, also known as SIDS, is a leading cause of infant death worldwide, with a global mortality rate of about 21% in 2019. The disease is defined as sudden unexpected death of a child under 1 year of age, and this remains unexplained after a thorough postmortem or investigation is conducted. The triple risk model by Filano and Kinney in 1994 has been used to study the disease. This includes the vulnerable infant, the critical developmental period, as well as outside stressors and environmental factors. Now, this concept of SIDS has been debated worldwide due to cultural practices and beliefs. A study done by Caesar et al. In Brazil included about 2,000 women. This study found that 8 out of 10 women had no knowledge of correct sleeping position of the infant, also that low educational level, high parity, and the increased number of persons in the bedroom played a risk factor for the increased risk of SIDS. Now, these women, despite having prenatal consultations, sleep positions were greatly influenced by maternal grandmothers as well as cultural practices. The Center of Disease Control in 2022 looked at the sudden unexpected infant death case registry in the US, and they discovered that of the 1,800 deaths between 2011 to 2014 at the scene of the infant's demise, 79% of them had soft objects that obstructed the airway, and 69% had used soft mattresses. Now, the rationale for this study. This is an unfortunate one. But here at Princess Margaret Hospital, our pediatric department had noticed that there was an increase in infants' mortality rate and infants being brought in dead to the emergency department. So for the month alone in February 2024, we had about 3 infants who presented to the emergency room who were unresponsive or brought in dead. And this number is significant given our population size of only approximately 300,000 people. Now, according to the World Health Organization, the infant mortality rate in the Bahamas for 2022 was 7.69 per 1,000 live births. Now, unfortunately, the percentage of these deaths attributed to SIDS has not been investigated or determined. We currently have not found any published data on the mortality or the common cause attributed to SIDS in the Bahamas. My aim is to assess how knowledgeable parents and caretakers are on the etiology of sudden infant death syndrome, including the risk factors, as well as the methods of prevention in New Providence, Bahamas. Now, my objectives were to determine the demographics of the participants, as well as their knowledge on the risk factors and the preventative measures for SIDS. For my methodology, the study setting and participants, this involved both parents or caretakers from the public sector, including the main hospital, which is Princess Margaret Hospital, and private sectors in Nassau. The interviews were conducted with parents of infants under 12 months of age, and this was either on the obstetric wards once the moms had delivered their infants or at private offices during the infants' appraisals. And ethics approval was achieved from the Public Hospital Authority, UE Ethics Committee. For my study design and sampling, it was a cross-sectional study with a quantitative approach, with participants selected through convenience sampling. The data was collected using online questionnaires via SurveyMonkey, and this was between the periods of June to August 2024. For my inclusion and exclusion criteria, the inclusion included parents or guardians who had an infant under 12 months of age, and excluded were if the parents were not the primary caregiver or if their child or infant had a medical condition like GERD or upper airway obstruction. The sample size was 251 participants. This was based on a 95% confidence interval and a 5% error on how we arrived at this number using RAO-SOFT. The instrument was adapted from another study by A. Algoez in 2021, where they had 30 questions in the questionnaire. And from this, we used the knowledge score, which ranged from 0 to 6. With 0 to 3, score meaning the participant was not aware of SIDS, 4 to 5 meaning they had acceptable awareness, and 6 meaning that they were fully aware. For data protection and security, we used SurveyMonkey, which was a paid version where we were able to secure the data. And to analyze it, we used Stata statistical software. And confidentiality was maintained throughout the study by the research assistants. For our statistical analysis, we use both descriptive and inferential statistics. For descriptive, we use categorical variables like education level and salary with N in percentages, and continuous variables like the amount of cigarette use or the child's age, which was represented with means or medians along with variance and standard deviation. For inferential statistics, this included a 5% error level and a 95% confidence interval. We also use odds ratio and ordinal logistic regression. And in some instances, we use Pearson chi-square as well as Fisher's exact tests. For my results, we looked at the age group, which included 47.1% being between the age of 25 to 34 years of age. For nationality, the majority of participants were Bahamian at 79.3%. For the relationship to the infant, the majority of participants in this study were mothers at 98.4%. In regards to the participants' level of education, the greatest amount was noted to be secondary level education at 63.1%. And in regards to the smoking status of the participant, in relation to the infant, we found that 68.6% were non-smokers. For the method of feeding for the first 2 months, we found that approximately 93.5% had some form of breastfeeding. This is significant because breastfeeding is known to be a factor that decreases SIDS. In looking at the sleeping practices of the infant, the majority of participants placed the infant on their back, which is the correct sleeping position at 54%. However, 16.1% placed them in the parent's bed, which is the incorrect place to place them. And 76.9% use a thick blanket or comforter, which is increased risk for SIDS. And 51.7% use soft mattress versus firm, which is a firm mattress is preferred use for an infant to prevent SIDS. In regards to pacifier use, 62.5% said they would not use a pacifier. However, studies have shown that pacifier use actually helps to decrease the risk of SIDS. And alarmingly, 70.9% place an object in the infant's bed, including a pillow, toy, or blanket, which definitely increases the risk of SIDS for the infant. And 75.8% said that they would not have their infant sleep from a separate room, which is actually accurate. It should not be before 6 months. Now, when looking at this slide, a question was asked in a different format. The infant was known to be sleeping with the parents at nighttime at 61.9%, and 9.6% actually had some form of sleeping with a relative who smoked. For the source of knowledge, 61.1% found information of SIDS from social media content or online, and only 24.5% were fully aware of SIDS when we looked at the knowledge score. In looking at the factors associated with knowledge, educational level was the only factor that had a significant impact with a p-value of 0.04. And looking at the odds ratio, had a 2.43 increase interval for educational level and its relation, meaning that the parents, if they had a lower level of education, they most likely had a lower score. So for my discussion, there was a significant correlation between educational level and SIDS. Many participants, they lacked full awareness and they practiced unsafe sleeping practices. Smoking was a major risk factor. And while many parents knew what to do in terms of safe sleep positions, dangerous behaviors still persisted. And this could be related to inaccurate online resource information or outdated information. For my limitations and strengths, looking at the limitations to gender bias was mainly mothers, where mothers usually are the ones who bring their child for doctor visits. The study location was at Princess Margaret Hospital. We could use a more diversified place in looking at the rural islands, because we have 17 islands within the country. But just of note, PMH is a good area to look at because this is where all of the islands come for any emergencies or any patients present for any healthcare aspects. And for the smoking details, could have identified what was the substance smoked and who was the smoker in the family. For recommendations, we want to promote healthcare education for the public at large, ensure that healthcare workers are educated so they can assist with educating the public, advise the government and let them know how important this is for us to actually make the country at large aware, and then also develop partnership with the pathology department in order for us to find out what the mortality rate for SIDS is. And just to conclude, the lack of knowledge on SIDS is great. This could be due to healthcare literacy or cultural influences, and more research is needed to determine the mortality rate. These are my references. Thank you very much. Any questions?
So I would like to invite the presenters to come to the front. Dr. Lockhart, please stay online. And I'll open up the floor to questions. Who has the mic? Where's the mic?
You, Dr.
Oh my gosh. Oh.
No questions?
Oh, no. All right. All right, let me start with Dr. Lockhart. So presentations were very well done, and I liked a lot of the literature, going through some of the definitions and providing some figures was really well presented. Dr. Lockhart, I was just wondering, you picked up something with smoking, and I was just wondering how that finding related to what is actually in the literature.
So in the literature, thank you for the question. In the literature, we note that if an infant had any exposure to anybody who smoked, so that's whether or not they smoked around the child or not, once they smoked in general, it increased the risk of SIDS for the infant.
Dr. Lockhart, since you're up there, when you're presenting your risk factors, it would have been nice for those of us who don't study SIDS, for you to highlight the bad ones, like, Prof said smoking, to highlight which were the bad ones and which were not so bad. So we could see the comparison easily. You did a lot of demographic data. Well, I think you came back to it. So what is novel about your work that it should be published?
Thank you for the question. So what's novel about our work is that we have not had a study like this done in the Bahamas before. Also, in the beginning, I wanted you guys to note that we had an increase in the amount of infants that were being brought into the hospital unresponsive or brought in dead. And that is a huge impact. We don't know what the cause would be. All we can do is speculate as a department, because based on our history and our clinical findings, a lot of the things suggested that it may have been SIDS, i.e. the mother rolling on the baby, or they found a baby with milk around the mouth. So that's why this here is a study that would be very necessary and timely, just because it's never been done before in this region.
Thank you. I'm going to go to Dr. Wisdom now. Please go to the mic. You said that there were no studies done on food behavior and sensory pattern in ASD in the Caribbean. Do you have a hypothesis why it should be different in the Caribbean than in Latin America or in Europe? Or do you have a hypothesis for that?
Repeat the question, please.
You said one of the bases of you doing this study is that no studies have been done in the Caribbean. Do you have a hypothesis whether it should be the same or different, and why should it be the same or different as another region?
Thank you for the question.
You can say no,
well, I think from the findings from our study, we had aligned with the global findings that food selectivity was a problem that's a problematic feeding behavior amongst the ASD population. And we just hypothesized that because based on the fact that just the underlying condition of autism spectrum disorder, they have sensory challenges, and that will impact their behavior around food and meal times.
What about genetics and the microbiome, for example?
So there is data on the gut-brain axis, but all of it is hypothesized, and this has actually been proven.
All right. You also said that you found a 28.9% rate of obesity compared to 8% globally.
Of the global children rate of obesity.
Yes.
Right.
Oh, just in the general.
Right, in the general population, but for other studies across like Europe, USA and Canada, our obesity prevalence was actually in keeping with theirs.
Okay.
Usually around 20 to 30%.
All right. So I know it's late, but what drives your obesity? And just tell me what is the novel thing about your study to publish in my journal?
Okay, so we've identified that feeding difficulties is common amongst the ASD population, and there currently isn't any standardized dietary regime in the management of ASD. And so I think this study kind of opens the window for future studies to identify those who have limited dietary intake, which puts them at risk of nutritional deficiencies and the risk of weight disorders such as obesity. And then this will then open the doors for future research and hopefully will guide and shape guidelines and policies in creating ASD-friendly feeding interventions.
Thank you very much.
You're welcome.
All right, that's it. Yes, he asked my question, so thank you. I'm satisfied with the answers.
All right, thank you.
Yeah, so Dr. Kudrow. Right, so I really liked how you set out your review, your background, and you showed us your sample size calculation, and you actually got 83, which was more than what you needed. So you had some nice data there, and then you had your comparison of the parental group educations. You presented the data, but you didn't actually do any inferential statistics, and perhaps that's fine because it wasn't probably not part of your objective. But my question to you in terms of future work, did you see anything there that, you think is worth probing? Was there anything that, may have stood out, even though you didn't actually do the statistics for that to see if there was any significance for any of the factors that you were comparing?
Thank you for your question. One of the things that we have to look at when looking at the children's sleep habits questionnaire to compare the group that scored less and the group that had high sleep scores and this group that had lower sleep scores is that we can have cultural differences that can affect how parents perceive sleep habits and thus how they report on the sleep score. So for example, in the Caribbean, co-sleeping is very common. And so this can be one perception that affects the way a parent answers a question. Other things that we can look at would be environmental factors. For example, in places where noise pollution is very prominent, that can result in frequent night waking in children, which can affect the sleep scores. So those are some of the things we can probe a bit further when looking at the questionnaire.
Thank you. And my regular question, what's novel about your study?
Thank you. So children with autism spectrum disorder are a vulnerable subpopulation in pediatrics, and their challenges often not only affect them, but the entire family. And so knowing that we know how sleep is so important in a child's development and the challenges that children with autism have, it is very important to look at the data that is coming out of Jamaica, since we unfortunately do not have any, and we see where it compares with studies done globally. So this would be very important to publish this study so that we can, so the data that's coming out of Jamaica can be seen, and so further management strategies and further studies can be done in regard to autism spectrum disorder and sleep.
Thank you very much.
All right, so I would like to thank all the residents who presented. The judges will, 5 minutes, under the guidance of Price, Waterhouse and Coopers, will go to their room. While we are waiting for Abbott to come down, I would just like to use this forum to really point out and acknowledge the specialists at the Bustamante Hospital for Children. As you see for Spanish Town Hospital, that they had the ophthalmologist and they also had the cardiologist. And so I would like to use this forum to acknowledge that and to thank them, right? And, in our research, if we didn't have the specialists, we couldn't have the research. So let's just thank them as I welcome Genevieve to the podium.
Good evening, everyone. My presentation should be like really riding a bicycle, but the bicycle is absent. So that's what it is. Just imagine the bicycle, and the bicycle is Pediasure. How can you not ride Pediasure? Whenever you think of this child in front of you, there has to be history taking, there has to be profiling of that patient. And one of the big questions that really you ask your mother, how is the child eating? Is the child eating? Because you're going to see a child who's going to be presenting, maybe looking like Genevieve, a little overweight, or maybe scrawny, really trying to come up, not impressing the scale at all. And so if you just think Pediasure, I want you to think that there is Pediasure original, there's Pediasure with fiber, and there's Pediasure sidekicks. Any one of those can meet the needs of the patient in front of you. So is it Pediasure Original, 240 calories, less than 1 gram of fiber, 7 grams of protein, or do you want to add fiber to that? So 3 grams of fiber, 240 calories. Now, if that child is looking like a good offspring and representation of Genevieve, you might want to go to the Pediasure Sidekicks. It has 25% fewer calories. Okay, but it gives you 10 grams of protein, which we say is 40% more protein, and it carries that 3 grams of fiber. And I'm going to ask you to remember why fiber is so important. That child might not be having veggies, might not be having fruits. I've said to some of my pediatricians, my residents, just think of a drive-through kid. The mother is going to the drive-through, whichever the fast food, and all the child is going to have is fries and juice. They are not engaging with the patty, with the protein, and they are picking out all of the lettuce and everything. They need fiber. That's where the sidekicks can come in. So your sidekicks fills the gap. So that's what you have. Apart from our Pediasure, I want you to remember three other products. Alimentum, extensively hydrolyzed, manages your colic for your child 0 to 12 months. Your Elicare, when you're not asking the gut for anything, but you want to give, Elicare is totally elemental. So it is sole source nutrition, but elemental, free amino acids. And then for your child 1 to 13, who really needs support because there's malabsorption, maldigestion, or compromised fat metabolism, there is your Pediasure peptide. Every one of those products can be sourced from CariMed, or they are in your inventory. Like Bustamante has everything. And that's where I stop this evening. My 5 minutes, Pediasure is like riding a bicycle. Once you see it, you know.
So I would like to thank Genevieve. And guys, she did it off her cuff because unfortunately her presentation was not projected. So I think we should give her another round of applause. And the residents can learn from this. Sometimes things go wrong, but you wing it. All right. So we'll just wait. Hopefully, they are tallying the scores. Yes, they are double checking it. They are looking for any errors, any statistical significance. Okay. So we'll just wait. I can neither sing nor dance. So we'll just wait. I don't think the residents want any more questions. No? You want me to open up the floor? No. Okay. We'll not open up the floor. Where's my... The judges have deliberated. They have tallied the scores. And we await their deliberations and comments. Sure, definitely.
Prof. Pierre is going to come and announce the winner. I wrote down a few comments from the...
So this is Professor John Lindo, and he's now going to give a few comments.
All right. So at two matters. First, I'm very qualified to give a few comments because I have about 80 publications. And this is one time I don't mind being called a 2-minute man because it's very late. So to get your papers, first thing I must say that I thoroughly enjoyed this session. I stayed focused throughout, and it's very hard for me to stay focused for more than 5 minutes. So I want to make a few comments. When you're preparing a paper for an international journal, remember that you're competing with people from across the world. And that is why I keep asking, what is novel about your thing? If you tell the editor, say, I found this in Spanish Town Hospital, and he say, oh, so go put it in a local Spanish Town journal. You have to generalize in your whole presentation, starting from your title. So you can say a tertiary hospital or a teaching hospital or a peripheral hospital, or it's fine. Drop the methodology and stick with materials and methods. The other thing I tell my students never to write, because we're not archaeologists, we are scientists. Do not say documenting this. You are trying to determine, okay? You have to use those positive language in your paper. Document means say you could just go over to, I'm a microbiologist, you could go microbiology, look through the records and document them. That has been documented before. You're doing more than that, you're adding value. And again, in adding value, you are highly trained pediatricians. You have to use your knowledge. Just don't look in the docket and say, yeah, take this out of the docket. You're always thinking about your training that you have and what value you're adding to the study. Sample size calculation is important. What I wanted to hear with some more excitement, you know, everybody say, we document this, we document that. And in the same voice, I don't hear one man say, we found. So when you come to your discussion, sit and think about, what did I find that is novel? What did I find that stands out? Because this is going to inform, you know, clinical practice, is going to inform policy, and you have the knowledge as, again, highly trained pediatricians to bring that knowledge. Prof. Williams said in your literature reviews, she thought that you didn't spend enough time on talking about study design. Where he said, for example, he said, you know, Linda found this. Was it a cross-sectional study? Was it a retrospective study? And so on. I think you're too hard on yourself, knocking down retrospective studies. The studies were very good. Nothing wrong with a retrospective study. Okay, you can publish this. Do not discuss things outside and make conclusions outside of what you have studied. Stick to the study you have. I think you did an excellent job on the statistics. You all had good ethical approval, and this is not a trivial matter because in some settings they don't. So I want you all to give yourself a round of applause for an excellent evening. And thank you very much for the opportunity to come here and be with you. Thanks.
I now invite Professor Russell Pear to come to the podium.
On that. Thank you so very much. Really and truly, it's been a wonderful evening. You all did really well. I stayed awake through everything. I'm supposed to say who we won, right? And Lindo? Some comments? He did comments already, so I'll say who won. So, but our decision was unanimous that Dr. Daniel Wisdom got the highest score. And why it was unanimous, the quality of the study, all right, the design, your presentation was very clear. I didn't have to be looking at the slides and looking through. They were very clear. And you were articulate, you defended your questions very well and admirably. And I must say, well done.
I would like to now invite Professor Christie to come forward. Go into the.
I too want to congratulate not only Daniel, but all 13 residents. You were all outstanding. I'd like to thank your families. I'd like to thank your supervisors and everybody who more or less bigged you up. I also want to say that we have to remember that we are an academic institution in the Caribbean where very little information is coming to the world as it relates to pediatrics. So I'm going to recommend that all 13 of you present your already written abstracts, because I know they're done, to the World Pediatric Congress, which is going to be in Scottsdale, Arizona later on this year, and also the American Academy of Pediatrics, which is going to be taking care, the conference is going to be in Denver, Colorado. And you need to submit these to the global health track. I think the global health track will be just right because essentially you will be competing against people from other developing countries, just like ours. We don't have to be perfect. We just have to be good and excellent at what you did, and you did a great job. So I also want to put up a plea, as well as I always do, that you still have to put together those 5 tables and/or figures comprehensively, working with your supervisors to get those papers published. Abby said 2 years, but I think 2 years is much too long. I believe you are now going to be worried about exams in another 6 months, and I think it's now time for your supervisors to step up to the plate and help you to get this work out of the way so you can at least have your first draft in the next 4 months before you leave, right? And you lose focus and lose interest. I think everything that was presented today deserves publication. And I want to also thank Abby and the team, and of course, Prof. Pierre, my favorite, you know, with getting this started. And I think you all did extremely well. And over 3 years, I've just seen tremendous improvement. Just keep going. You got it. And you
Wait. Photographer. As the photo ops are going on, I will invite Dr. Cavallo.
Okay, good evening, everyone. I know it's very late, and I was asked just now by Dr. Rucraig to keep it short and spicy. So I'm going to aim to do so. Distinguished guests, colleagues, the panel of judges, moderator, sponsors, presenters, and everyone who joined us today for this remarkable event. It is my honor to deliver the vote of thanks and closing remarks for the 3rd Annual Pediatric Research Forum. I want to start by saying how much I relate to the presenters tonight. I was in the exact position a few months ago, standing here, sweating, very nervous, going through my slides, hoping I wouldn't forget my key points or worse, trip on my way to the podium. Thankfully, I didn't trip, but I still remember that one judge who raised an eyebrow every time I spoke. It has truly been an inspiring evening filled with groundbreaking research, passionate discussions, and a shared commitment to advancing child and adolescent health. Each of the 13 presenters today has showcased the depth of inquiry and dedication that define our field. Whether you focused on clinical outcomes, public health interventions, or novel therapeutic approaches, your work has made an impact, and I have no doubt it will continue to shape the future of pediatric care. I would also like to congratulate Dr. Wisdom, this year's best presenter. Selected by our esteemed panel of judges. Dr. Wisdom, your presentation stood out for its clarity, depth, and potential impact on pediatric care. We hope to see this research published, everybody's research published, of course, and contribute to the body of knowledge in our field. A special thank you goes out to our panel of judges who graciously dedicated their time and expertise to evaluate these presentations. Your guidance and feedback are invaluable to the growth of our presenters and their future work. We also recognize and express our deepest gratitude to our sponsors for this year's event. Your support has enabled us to create this platform, which celebrates research and innovation in pediatrics. Your investment in events like these reflects your commitment to advancing healthcare in our region. To Dr. Melbourne Chambers, Deputy Dean of Graduate Studies, Dr. Harrison, Head of Department of Child and Adolescent Health, and all our consultants, all our pediatricians here, thank you for your unwavering support in fostering a culture of research and academic excellence. And of course, to the organizing team, faculty mentors, and all those who worked tirelessly behind the scenes, your efforts have truly paid off. Finally, thank you to all attendees, including our colleagues, faculty members, students, and supporters for being here today. Your presence not only encourages our presenters, but also fosters a culture of inquiry and collaboration that propels pediatric medicine forward. As we conclude the evening, I encourage you all to continue these conversations and keep pushing the boundaries of pediatric research. And of course, what better way to do this than over some well-earned refreshments, right? Thank you all once again, and we look forward. Okay, thank you all once again. We look forward to seeing you next year at our Pediatric Research Forum. And I did mention our sponsors. A big thank you again to our sponsors. Thank you for being here. And without you, this wouldn't have been possible for sure. I would say until then, let us continue to inspire, innovate, and collaborate. Thank you so much.